हेलो
तरफ से नहीं आ रही है, फोन की आवाज आप ही आ रही है। ये अपनी तरफ से म्यूट है क्या?
सर
Okay.
Yeah. Good evening, everyone. We welcome you all to Bombay Spine Society webinar on osteoporosis, the final verdict.
Full screen news.
So I hand over to the moderator for today, Dr. Abhay Nene, to take over the session and introduce the program. All are muted.
Sorry, I think I was out of.
Dr. Abhay Nene, you're muted. Can you unmute yourself?
I think it is Dr. Amit Jain who is going to take over now.
Yeah, okay.
So Neeraj, you lost somewhere in between, but anyway, Dr. Amit Jain, please take over, sir.
Yes, sir. So very good evening, all the faculty members and the delegates. All of us hail from some part of some of the country which is a part of the solar system. Finally, the, I would say, Milky Way galaxy, multiple galaxies, and finally we have the whole universe. So when we see from the perspective of the universe, we are almost invisible. But that does not mean that we are non-existent. What better than the current time of COVID pandemic would really vouch for this term or this statement that invisibility doesn't mean non-existent. Even though it is invisible, it has made huge impact on the life of each and every person of the globe. We can see we have lost more than 6 lakh people across the globe, and we have lost more than 35,000 people from India by now. Similar in terms of, like, as we are talking about silent or invisible COVID, we have another silent disease, which is osteoporosis. So again, disease being invisible does not mean it is not having any impact. Only those people who incur the fracture and the complication, they get to know that what is the impact of the disease on these people. So we being clinicians, we definitely to manage this, we need to look at a lot many aspects. What is the disease, pathophysiology, management, what should be the latest guideline, and how should the patients be managed in the best way. So for that, we need to definitely meet with each other and have conferences and meet with each other physically. But in this current COVID times, definitely it is not possible. So we are going ahead with this digital platform, that is webinar. Definitely in this pandemic time, definitely there is infodemic as well, that is pandemic of the information. So important thing is to have the right perspective, the right person whom we should listen, so that the knowledge which we gain should be in best interest of us as well as for the patient. With this background, I, Dr. Amit Jain from Medical Affairs Department from INTAS, on behalf of INARA Division, which is specifically dedicated to the management of osteoporosis, welcome all of you in this today's live webinar, which is on osteoporosis management protocols, medical and surgical strategies. I really feel delighted to have joined hands or to associate with Bombay Spine Society. So we really thank all of you from deep of our heart to give us this opportunity to have this platform for discussion on osteoporosis. Without taking much of your time, I would like to hand over the session to Gautam Javeri sir, who is course convener for today's event. Over to you, sir. Sorry.
Good evening, ladies and gentlemen, all the delegates who are watching us on this webinar on the internet. Today, let me start by thanking the INTAS team, Dr. Amit Jain, Javed, and Chandraketu, for helping us through their unrestricted financial grant in organizing this webinar. I would also like to invite and thank Dr. R.C. Meena, President of the Indian Orthopaedic Association, and Dr. Atul Srivastava, who is the Secretary of the Indian Orthopaedic Association, for joining us today. Today, this webinar is a co-sponsored program. Hello. This program is a co-program between the Bombay Spine Society and the Indian Orthopaedic Association. The goal of the webinar is to fulfill a lot of queries regarding osteoporosis and osteoporotic related fractures in the minds of the general orthopedic surgeon and the spine surgeon. Bombay Spine Society is known for its no-nonsense approach. Over the last 4 months, we have seen a number of webinars, including some on osteoporotic vertebral fractures. There have been webinars claiming that they've operated on patients who are 80, 85, 90 years old and there have been no complications. Other webinars have shown that they've put in 10 and 15 screws and patients are 4 years post-op absolutely fine, walking normally. Now, those webinars were a little difficult for us to believe. And what Bombay Orthopaedic Society is trying to do, Bombay Spine Society is trying to do with this webinar is to give you a very clear idea regarding the management of osteoporotic vertebral fractures. What is the method with which they present? What is the natural history of this disease? When should you investigate? And if you investigate, what investigation should you do? What are the red flags? What indicates to you that there is a danger and this patient is not going to do well with non-operative treatment? What is the non-operative treatment of osteoporotic vertebral fractures? Because there is a lot of controversy in literature, so it is basically based, surgeon-based. In addition, if the non-operative treatment doesn't work, how do we proceed further? What investigations are required? Is vertebroplasty an option? There has been a lot of controversy. There are papers which have said that vertebroplasty is nothing but a placebo. Is that true? If there is a role for vertebroplasty, what is the ideal timing for vertebroplasty? What are the contraindications to vertebroplasty? And if at all surgery is required in a small percentage of patients, what are the challenges we face during surgery? To help us with this webinar, we have a fantastic host who is written extensively on this subject. That is Dr. Abhay Nene from the Leelavati and Breach Candy Hospital in Bombay. And we have got the best of the Bombay Society, starting with our former president of the Bombay Spine Society, former president of the Bombay Orthopaedic Society, and former president of the Association of Spine Surgeons of India, Dr. Ram Chadda. Along with that, we have a second generation of very experienced and excellent spine surgeons in Dr. Arvind Kulkarni and Dr. Vishal Peshattiwar. And then, of course, we have a third generation of young Turks who are doing extremely good work, who are extremely well-read and will provide the academic background for this, such as Dr. Uday Pawar, Dr. Agnivesh Tikku, Dr. Nikhil Arbati, and Dr. Ankit Patel. So without much further ado, let me welcome Dr. Meena and ask him to say a few words over here, sir, to kick this seminar off. No. Well, we are still waiting for Dr. Meena. There has been some problem in his connection. I forgot to mention our dynamic.
Yes, sir. Are you hearing me?
Yes,
Gautam?
Dr. Meena, we can hear you very well.
Gautam, are you hearing me?
Yes, sir.
Yes, sir. Very good evening to all. Very good evening to all. I am really proud to see this kind of meeting on the very common and interesting topic, osteoporosis of the spine. That is it. Today's need in the degenerative age and lead to multiple problems associated with the osteoporosis and the synonymous problem degenerative, which causes a significant deformity and crippled life of the patients. In that scenario, how to investigate it, how to manage it, it is a dilemma for which it's a wonderful meeting you have organized. Dr. Vishal has organized it with the INTAS collaboration. And I hope this will definitely benefit all the listeners, all the candidates who are attaching with this meeting. And my all wishes from the IO House to the Bombay Orthopaedic Spine Society that it carrying the regular program on the spine to educate the learners in such a difficult time of COVID-19 pandemic crisis. I wish you all the best. And hope your program will be definitely much beneficial, useful to all orthopedic fraternity dealing with the spine. Thank you. Thank you, Gautam.
Thank you, Dr. Meena, for your blessings and your good wishes. I'm sure it's going to be a great program. And thank you. You are in the middle of the road and you have stood and taken the time off to welcome us. I would like now to hand over the mic to Dr. Atul Srivastav, Secretary of the Indian Orthopaedic Association, to say a few words.
Thank you, Dr. Gautam. And first of all, thank you, Vishal, for the kind invite. It is a privilege to be a part of this unique final verdict webinar on osteoporosis management protocols being organized by the Bombay Spine Society today. Well, Mumbai has been the spine of academic learning and teaching across the country over the years. The Bombay Spine Society also has trained innumerable spine surgeons who are successfully practicing the art and science of spine surgery across the country. I must congratulate you for the same. Once again, thank you for having me on board. Wish you all the best and good learning. Stay safe, stay sensible. Thank you. Jai Hind.
Thank you, Dr. Srivastav, for your good wishes again. And now, without much ado, let us go to the final verdict webinar. Yeah, no nonsense. This is the final verdict. And we have Dr. Abhay Nene to take you through.
Thank you so much. It's very exciting to talk about this case because it's a case that, that represents a plethora of cases that have been coming up of the last decade. And it's a regular 71-year-old active guy who's retired. He's a chronic smoker like, many Indians are. And he's had a domestic fall and he's come with this kind of an injury. The first question, of course, would be to Dr. Ram Chadda, that when this guy walks in with a relatively short history of a domestic fall, with an X-ray in hand, do you make a plan in your head? Is there an algorithm that you follow, or do you just treat on case, on case basis?
Well, he comes in with two sets of problems. One, he comes in pain, and two, he may come in with a neurology which may be evident or a neurology that he is keeping to himself, like a bladder bowel issue. Second, he comes in with a suspicious diagnosis of osteoporotic vertebral compression fracture or a pathological fracture. So with this, I would address this patient. I would treat his pain first and at the same time investigate him either towards osteoporosis or towards a pathological fracture.
So Dr. Kundnani, do you agree on day one investigations towards something suspicious, or would you like to treat and mitigate the current crisis?
Well, like Dr. Ram just mentioned, I think I would agree with him that investigate for sure to look for chances of failure of conservative treatment. So if I have to do any investigation, my investigation has to be done on day one to see if my conservative treatment will be helpful for this patient or not. And there are certain rules and findings available on X-ray. If X-ray doesn't prove any of those findings, then I'll be at least happy that my conservative treatment is going in the right direction and I'm not treating a wrong kind of patient with the right treatment there. So all the risk factors of failure, I would want to investigate and rule out on day one itself.
So in a nutshell, we're talking of whether to treat or investigate. Of course, you can do both together. Dr. Tiku, can I get you in here for the sake of diversity? We spoke of two kinds of investigations. One is about looking for something sinister as the ation, and the other was about whether this is an osteoporotic fracture that's going to sustain a conservative treatment, or will it need something more? Where do you stand? Treatment, investigate to see the mechanics of the fracture, investigate to look for something sinister.
Sir, I think in this phase where osteoporosis is not common, especially in a male, I would think of investigating as well as treating simultaneously. I will at least start the medical therapy for analgesia, but I would be my threshold for getting the investigations, at least the blood workup will be very less, if not a subsequent image.
Right. Dr. Peshetivar, if you had to do just one more investigation after this X-ray, what would it be?
I would, in this case, there is a more than 50% loss of vertebral height. And there is a definite history of fall. So the chances of this being pathological are less. But in this case, I would do blood investigations. I would do a parathyroid, I'll do a calcium, I'll do his sugars. I will check his vitamin D and folate levels. These are the known indicators of bone health. He is a heavy smoker. That's another red flag that he has. So if this, most likely these parameters are going to be deranged, and they will guide me to my next set of investigations.
Right.
But this is one of the rare one where I would not do one set of investigation on first day. I would do an MRI in this guy with a stir image to check the posterior elements, and also to check if there are any other, because the fall could be incidental.
Right.
The fracture
So
could
I
have led.
the thought process of most of the faculty is towards a more diplomatic or more defensive approach to this problem, because I think the more cases you see, the more you realize that all these fractures are not necessarily benign. Dr. Pawar, if I get you in here, if you had a choice between an MRI scan and a dynamic X-ray, what would you choose for if there was just one more test to be done?
So I would choose for an MRI in this case, because since he's a male, little bit of an oddball, but still I would choose an MRI in this case, basically to rule out any other contiguous elements or other fractures, other levels of involvement.
Right.
So yes,
Dr.
an
Arbati,
MRI.
what do you think, Dr. Arbati? Do you think there is a role of a dynamic X-ray here at all on day one to make any treatment decision?
No. So actually, what Ram sir had said, I agree. So first thing, I would look for any patient who comes with an X-rays to find out whether he has any neurological problems or is having only pain. So based upon that, I would further go for the investigations. If he's having any neurological complaints,
So
then
he's
an
walked
MRI.
in and he has no neurology, just to make things clear at the helm. He's walked into the clinic, he has no neurology.
Yeah. So basically, this X-ray, I mean, even if it's done supine, it's showing almost more than 50% compression, but he's having no neurology. So I wouldn't go for a dynamic right now, because my stress would still be on a conservative line of management. So like what Dr. Vishal said, I would still stress on maybe getting a parathyroid hormone and a bone densitometry done under D3, and then manage him conservatively at present. And at the same time bracing, and at the same time warn him of all the future things and all, as in the management point of view.
Right, right. Dr.
But
Patel, the
immediately.
question to you is that when would you ask for a dynamic X-ray on day one? Or would you at all ask for a dynamic X-ray on day one?
Thank you, sir. I will not be probably doing a dynamic X-ray on day one because the patient will have pain. But since in this patient, he has a anterior as well as posterior height, which is less than 50%, and the AP X-ray also shows a splaying of the pedicles, this probably looks like a burst component as vis-a-vis a very typical osteoporotic fracture. So he is probably unstable, and I'll not like to aggravate the instability by doing a dynamic X-ray.
Yes, Dr. Pawar, Dr. Patel said this is more, looks like a burst fracture. He gave a very specific point that it's the anterior as well as posterior height loss, which makes him suspicious. What are your comments on this, Dr. Pawar?
I wouldn't be worried about an anterior and posterior equal loss of anterior column and posterior column. But the point which I wanted to stress out was at some point of time, you'll jot down all the investigations for sure. Treat side by side the patient, but jot down the investigations and tell the patient that you might need blood investigations, you might need some further radiological investigations, and further specific investigations. So treat side by side as well as you investigate side by side.
Right. So I think it's loud and clear from the most of the faculty that we want to be defensive and you have to have your disclaimer in place. And your mind will only, I mean, your eyes will only see what your mind knows. So we all should be aware of all the possible, options here. Unlike in the olden days when a fracture like this would be just sent home on analgesics. Dr. Kulkarni, if I can get you in here, and can you please touch upon the box below? Assuming that your day one red flags have been cleared, and what sort of treatment do you recommend?
I remember vaguely something.
Can everyone else mute their mics because there's someone cross-talking on the mic? So if you can mute all your mics and only unmute them when you're being asked a question or when you're speaking up, you can do that on your own merit. You don't have to wait for me to ask. Dr. Kulkarni, what's your prescription to a patient like this?
So first we need some type of a preliminary diagnosis. So as we are taught to understand that you should first think of common diagnosis. So the most common diagnosis in such a situation is the osteoporotic compression fracture. So you give the patient analgesics, the routine analgesics that we give, and we advise bed rest for till the patient is a bit comfortable to move around. Medications you should avoid.
You don't like to give a number to the amount of bed rest. You don't say 6 days, 8 days, 3 weeks. 6
No, there is no empirical. Actually, this is basically activity is limited by pain. Anything that is possible without pain, the patient can go ahead and do it. So the activities are limited only by pain. So patient can move around, etc., and with a brace.
So you're saying actually there's no bed rest.
No bed rest.
And can you please define the brace? What sort of a brace? This is
So
the
this is
T12.
involving the thoracolumbar region. So I basically the fracture is going to collapse with kyphosis. So we don't want a kyphosis to occur at the thoracolumbar junction. So we give a hyperextension brace that can keep the thoracolumbar spine straight in extension. Right. And one of the analgesics that is suggested is the calcinase spray. I probably will be discussed during the presentation on the management. Calcinase spray has been advocated as one of the analgesic for such kind of fracture, along with other analgesic treatments. Apart from that, ice packs, all kind of symptomatic treatment. And since, as I said, the first diagnosis, the most common diagnosis, that is of a compression fracture, you definitely want bone mineral density of this patient because you want to treat osteoporosis when the patient comes next time. So one of the most common malignancies that we see in elderly patient is multiple myeloma, and it just takes a serum blood test to diagnose the same. So when the patient comes with BMD, he might as well come with a report of his electrophoresis.
Right. So just on that brace, Dr. Kundani, how strongly do you feel about bracing in a patient like this? You're muted, sir.
Oh, sorry. Yeah. So on day one, I would actually, like I said, I'll be surely investigating to rule out all the risk factors of failure, be it even if requires doing MRI. Day two, I think the first and foremost is to make this patient comfortable in terms of pain relief. Patient is not here for cause, he's here for pain. And to take control of pain, I would surely not mind bracing this patient if the patient is ambulatory, to keep his pain at the bay while he's being treated with all the other modalities, whether we are investigating or treating.
And
so
would it also be a hyperextension brace for you?
Not hyperextension, something that will just give him comfort level. It is surely not going to put him in hyperextension, but it's like a lumbosacral corset, which is one little higher thoracolumbar junction, to just keep him safe and try to give him like semi-rigid kind of immobilization of the fracture site to give him at least pain relief so that he keeps mobilizing out of the bed.
Does anyone in the house have something strongly for or against bracing in these people? Assuming not. Dr. Peshartiwar, when would you ask him to follow up? Now that you've given him all these instructions, when would you ask him to follow up?
So usually I investigate all my patients on day one. With what in this patient, I would be extensively investigating them to see the nature of the fracture, the posterior elements and everything. And once I'm sure that this is a benign osteoporotic fracture, I ask them to see me after 2 months. I put them on restricted activity for at least 3 weeks. There is a supervised physio visit once a week to see that they're doing their chest therapy and supervised rehabilitation. There is no role for complete bed rest in any fractures anymore. If there is something that needs complete bed rest for 2 months, you might as well fix it, because a 71-year-old 2 months on bed is going to get up with a very more serious problem of having lost his physiological what people call a stamina. So that is, I rather put them on restricted activity where I would ask them not to sit, not to bend forward, or not to give torque to their back.
Sure. So
I will have definitely
2-month follow-up. Nikhil Arbati's eyebrows went up, so I'd like to ask him, when would you ask for a follow-up, and do you have a problem not seeing the patient within 2 months of your first visit?
So actually, I mean, even if it is a benign and the patient has pain, and when I've ordered investigations like bone densitometry and all, still I would call him after 3 weeks follow-up, the first follow-up. And that time, 3 to 4 weeks, and I will just get a check X-ray done again. If the pain has subsided, I would recommend that he get a dynamic or a standing X-ray at that time. So my first follow-up is usually at 3 weeks.
Yes, Dr. Zaveri?
Yeah, just wanted to make a point that some of these fractures, especially the ones where there is a posterior element fracture, like posterior wall fracture, like Ankit pointed out, is a burst fracture. There is a higher risk of these patients developing a delayed neurologic deficit. And typically the delayed neurologic deficit comes within 2 to 3 weeks after the start of after the initial injury. And therefore the early follow-up is essential in this kind. If it was a simple wedge compression fracture, I would agree with Vishal that maybe we can go a little later in terms of follow-up. But in a patient with a burst fracture, I think we should keep it under observation a little bit more aggressive.
Right, great point. So a lot of great points coming up. Dr. Tikku, can you finally sum up on this calcinase spray controversy. There's been a controversy about calcinase spray, about it causing malignancy. It was banned in Canada for some time. Can you enlighten us about the current status of calcinase spray, Dr. Tiku?
The calcinase spray right now has been recommended not for treatment of osteoporosis. This has been the treatment for osteoporosis has been withdrawn even by the European counterpart of FDA. So it has some mechanism by which it can influence the pain by acting on opioid receptors. So for a short-term use where you are trying to give some additional relief to the patient and try to prevent bone resorption, it will be helpful, but it is not meant for a long-term anti-osteoporotic use. Anyways, after 2 to 3 months of use, antibiotics can antibodies can develop against the calcitonin, so it becomes useless after that.
Right. Has the FDA allowed it, or has it been banned still?
Sir, it is still allowed for certain limited indications. One is hypercalcemia because of recumbency, where there may be increased resorption, and for short-term pain relief and certain type of case where it can cause a severe bone loss or bone resorption. But for osteoporosis, it is not recommended for. It has been withdrawn for use in osteoporosis.
Right. Thank you so much. So I think from this first bit of discussion, it's come out very clearly that the faculty wants to be on the safe side because they've seen too many things going wrong. So look out for instability in the regular OVCF. Look out for a potential cause that's asides of a benign osteoporosis. Investigate accordingly and look for the day one red flags, because that's what's going to make or break this case. And while Dr. Uday Pawar takes over to give us his 5 most important day one red flags, I'd love to ask Dr. Zaveri, Dr. Kunnani, Dr. Ram Chedda, and Dr. Kulkarni in that order, what is their single most important red flag on day one? Starting with Dr. Zaveri. Dr. Kunnani, your most important red flag on day one.
So I think on X-ray, if I find findings of posterior interspinous distance, which is really eye-catching, I would really be skeptical. A burst split fracture of the body, I will be really skeptical. Any translation or subluxation, I will really be skeptical. If there is
So if you had only one, you've already answered it, right?
Yes, posterior ligamentous complex injury of the
clinically or radiologically. Dr. Ram Chedda, what's your most important red flag on day one?
My most important red flag on day one is I keep asking leading questions about bladder and whether the patient has got any issues with his or her bladder. The reason being, that's a major decision between non-surgical and surgical. A lot of these people who have some change in their bladder function are the ones who within 2 to 3 weeks, as Gautam mentioned, will be those who will develop neurology in sitting position, which will disappear on lying down position. So that's something which I am very, very particular about.
Right. Dr. Zaveri, what's your one single most important red flag on day one?
I think on the day one, if the patient has got pain, back pain, and you see an X-ray which is has a fracture, but there is no history of fall, it is a spontaneous fracture, then I'm worried, because it means that there may be a pathological fracture inside secondary to an infection or a tumor or something like that.
Right, so, very important. Very important. And Dr. Kulkarni, one single important red flag for you? You're muted, sir.
It's been addressed by Ram.
All right, lovely, the bladder. So Uday, you've been given a carpet to walk on. So can you please take over? Dr. Uday Pawar, he's going to tell us about the most important 5 red flags. It does not mean that there are not more than 5, but we're only going to talk about the most important 5. Over to you, Uday.
So my screen is visible?
Yes, absolutely.
So I'm going to discuss within 5 minutes, what all the 5 or 7 red flags which I've sorted out. So it depends on what day one red flag is and depends on when you see the patient. So not specifically in any order, I would start thinking about these 5-7 points. Whether dynamic X-rays, the fracture morphology, is there a Kummel's lesion on day one? What's the status of the posterior lateral ligament complex, the junctional area, and obviously clinical and neurology. So not in any particular order, so mind that. So dynamic X-rays, if I have more than 20 to 25% of wedging or dynamicity to the fracture, I'll be a little bit worried about giving just conservative treatment and following him after 3 to 4 weeks. So I'll observe this patient and follow up very closely. Morphology 25 years back paper by Sugita, telling us about X-ray to see which are the troublemakers. And if you see the lower three, these, if you see on an MRI or an X-ray, this was an X-ray, but if you see these on an X-ray, it just tells you that you just have to be careful regarding these fracture types. And importantly, if you cannot identify this thing, the more surface area that you have for these fractures, so a swell type, a bow shaped along with a consult in a compression or a projecting type. Basically what they're telling is more surface area involved. Just be careful regarding whether this patient are going to land up into kyphosis or a non-union. Similarly, MRI wise also, it again mimics the same things. If there is a more surface area involvement on either a T1 weighted image or a T2 weighted image, you should be careful about these folks and follow them up a little bit regularly. So X-ray and MRI tells you that. We used to be very happy when we used to see this Kummel's lesion or Kummel's sign earlier when we all started treating this thing, because we used to feel that there is a space available where a cement can go in easily. But unfortunately, that's not the case, as we know now. So not only for conservative treatment, even for your only vertebroplasties, having a non-union or a Kummel's lesion inside the vertebral body is a significant red flag for conservative treatment, as well as doing a vertebroplasty or alone vertebroplasty. In this scenario, I would add to a minimally invasive fixation to this patient, but mind and see for a Kummel's lesion. Now, all these fractures are generally thoracolumbar, and as we know, thoracolumbar region has no kyphosis, so zero kyphosis. So you can't take any kyphosis, any local or a global kyphosis. And as we had discussed earlier, taking a cue from spinal trauma, look for the posterior lateral ligament complex and specifically look for it in a STIR MR image, whether there is any glowing sign in the posterior region of the fractured level. So you can't conserve those. Basically, it's a 3-column injury and you cannot necessarily conserve those. Not to mention, slowly, as you start following these patients, a worsening pain or no relief in spite of your so-called conservative treatment, significant instability signs, clinical signs are a red flag that the patient is not going to recover as we want him to recover. So either week or second week or third week, I would have a low threshold if the patient complains of significant pain, which is limiting him from doing his day-to-day activities as well. And I wouldn't hesitate to stop my conservative treatment of bed rest, bracing, analgesics, and limited activities, and even offer him some sort of an intervention from my side. We all know the obvious neurology is a significant red flag, but a different type of neurology has in osteoporotic vertebral fracture, in the sense that they have a dynamic neurology, just a wobbly gait while getting up, while walking, and not a significant neurology. If you have a significant neurology of any magnitude, you shouldn't be conserving this patient. So the troublemakers in the last slide are the dynamic X-rays, as we spoke about. More surface area, more trouble. The killer Kummel's lesion you need to be aware about. The junctional issues and the posterolateral complexes you need to be aware about. And if you have a clinical or a neurological, it drowns all the above mumbo jumbo which we were discussing. If you have clinical worsening or a neurologic worsening, you have to stop your conservative treatment.
Fantastic, Uday. You've nailed it, because you've actually, if you can unshare your screen, you've actually covered the points, just absolutely what the doctor ordered. Does anyone in the faculty feel strongly about any point that was not covered in these 5? Because we had given only options to cover 5 points. Does anyone feel strongly about any point that they have seen in their clinical practice and they'd like to share with us, which is a day 1 red flag, which is slightly offbeat or not covered so far? Please feel free to unmute and talk while we get Dr. Peshativar and I want to ask Dr. Dr. Pawar, I'll just come back to you. Dr. Peshativar, this guy has, you asked him for a 2-month follow-up, but at 3 weeks, his pain is no better and he's quite disabled with pain, and he's come back to your clinic. And at this point, in your mind, it was a 2-month plan, but at 3 weeks, if he comes back with nothing worse, but nothing better either, do you just bat him out, or do you take cognizance or note of what that is?
That's the time I would do 2 X-rays.
Yes.
One would be sitting and other would be supine.
And how would that help, sir?
So supine is an unloaded spine. It will, usually if the pain has increased at 3 weeks, that's a big red flag for me. It means the instability is probably increasing. All my patients usually, unless it's a very benign looking on X-ray fracture, something like this would definitely have had an MRI to rule out all the other causes. So if there is pain at 3 weeks, then that on sitting, usually it will unmask the kyphosis, because all investigations, including MRI, are done lying down. And X-ray is the only thing probably you can do sitting, which will show you the position of the bones on a loaded, how to say, and I would...
Sure. Dr.
Try
Pawar, what do you feel about this?
So I would echo Dr. Zaveri's opinion that anything related to osteoporotic spinal fractures, benign osteoporotic spinal fractures, I think all of us can handle that. What we cannot handle is a metastasis, the root cause of metastasis. If there is a cancerous lesion there, be it primary or secondary, the whole dynamic osteoporotic fracture, I guess all of us can nicely handle. Even without a neurology, we can handle that. But the dynamics of the situation change, or a secondary which is sitting there. So I'd be a little bit worried about a blown out posterior cortex in these patients.
Right.
Infection
Dr.
and a blown
Ankit
out
Patel,
posterior
you have
cortex.
anything to add here? He's come back to you at 3 weeks saying, sir, my pain is no better and I'm in considerable pain, but on examination, there's no neurology, there's nothing new.
So as we had seen earlier that he was kind of a burst fracture, and then that has been seen here as well in the next follow-up X-ray. I will like to investigate and do an MRI to see if there is any chance of neurological compression or not, and whether to prime him up regarding the foreseeable change in treatment plan.
Right. Dr. Ram, if you can sum up this in the box, would you escalate treatment, like give him more analgesics, more bed rest, more bracing, etc.? Or would you start working him up for a differential diagnosis?
I am very aggressive in investigating. I may escalate the treatment part of it, but I'm very aggressive in investigating. And hence, I will escalate to whatever level I want. Please understand, every patient is different. And it a lot depends on the patient expectation and your counseling as well. There are some people who will actually want you to investigate everything on day one. And there are some people who will allow you to investigate and wait at 3 weeks. But there's something called as a low demand, low expectation patient and a high demand, high expectation patient. And your approach has to be tailored for that particular patient.
Dr. Kundani?
So I think this is very pertinent what Dr. Ramchandra said, and we have been discussing from the first slide itself, like you mentioned. If this patient has come back to you in 3 weeks, you already knew that in 3 weeks, no miracle is going to happen. But the first thing that surely happens, if it's a benign, healing, natural osteoporotic fracture, that means in 3 weeks, this patient will have at least 50% pain relief. And if patient's pain is not better even by 50%, I would strongly believe that this is not a primary idiopathic, natural looking osteoporotic fracture. Either it has some secondary factors which has led to an osteoporotic fracture like hyperparathyroidism or something, or it has some secondary disease to cause it, or it is one fracture. Despite being osteoporosis, this is bound to go into non-union, and it is better to catch them now. Otherwise, they'll come up with a very, very bad situation, both mechanically having a big defect to reconstruct or a neurological bad situation to really reconstruct.
Right.
So
Dr. Arbati, do you
catch them
strongly
early
agree with this statement that Dr. Kundani has made, that at 3 weeks, there should be at least a 50% improvement in the clinical profile, pain-wise?
Yeah. So actually what Vishal has said, I agree. I mean, if it's a benign fracture osteoporotic, your analgesics and all should show at least 40 to 50% improvement clinically. But having said that, this person is a retired with an active lifestyle. If he's come back in 3 weeks with significant pain, still no improvement, I think this would be the time to escalate not only the treatment, but the investigate point of view, because after all, the patient has come to you for improvement of the pain. And if you're just going to offer him an X-ray and tell him that, okay, we'll just give some treatment, he may not be completely satisfied. So first of all is to make him completely assured, get the investigation done, make him aware that, okay, this is nothing major or whatever it is, get him completely cleared or dead. And then you can escalate your treatment. So I would go with the full thing. I would get an MRI done along with a dynamic X-ray at this point.
Fantastic. So we'll invite Dr. Vishal Peshettiwar. Yeah, one second, Dr. Kundani. Can Dr. Vishal Peshettiwar share his screen while Dr. Kundani makes his point? Vishal, can you please share your screen? Yeah.
So there's a question from the delegate that, is multi-level fracture seen on X-ray on day one also a high red flag to investigate them aggressively?
Right. So can Dr. Tiku take this? Because I think he's been a part of a project that worked on this. Dr. Tiku, multi-level fracture on day one, is it a red flag?
Multi-level fracture on day one, I would think, is a red flag for early mobilization. We still need to try to get them out of the bed as early as we can, but you still mobilize them guardedly. And rather multi-level fractures, they are even more difficult to treat surgically. So you might as well conserve multi-level fractures rather than think of operating on them. But yes, go slow on mobilization, keep a strict check on neurology, and give them adequate bracing so that they don't go into.
Great. Important insights. Dr. Chadda?
My point here is a lot of multi-level fractures are not fractures with the same accident. You will be surprised that if you then investigate them further like an MRI, one may be the one which is the acute painful fracture, and couple of them may have occurred in the past which the patient is unaware of. So please, if you have multi-level fractures, means that probably this patient is osteoporotic and been there for some time.
Right. Someone in Dr. Mantu Jain from Orissa has actually pointed out that will this be a sign of a metastasis? Or does anyone have any comment, Dr. Kulkarni? If it's a multi-level fracture, could be myeloma or metastasis?
Yeah, I was coming to that. So suppose you have a patient, especially, has compression fractures in the dorsal spine, and she's a female, and if there are multiple of them, there's no history of any trivial injury, you can't just pass it off as an osteoporotic compression fracture. It could be metastasis. Right. And similar is the situation in an elderly patient, in the lumbar spine, 2 or 3 level involvement, no history of trauma. You should have a strong suspicion of something like, prostate spread or, multiple myeloma, etc.
Sure. Quickly, Dr. Zaveri, would you agree with everyone's opinion that an MRI and a dynamic X-ray seems like your next best investigation? Or do you have something else in mind if you were to just do one investigation?
No, I would agree with them.
Right. Dr. Pawar, you had to say something and then we'll move to Dr. Pesha.
Yeah, I would look at it in this way that your diagnosis of osteoporotic fracture should be a diagnosis of exclusion, even though you know that this is an osteoporotic fracture, this will be an osteoporotic fracture, but in your mind, you got to always think about what am I missing, and you need to chase the red flags and the bad guys.
Right. So in the background, you should always be thinking of something sinister. Dr. Chedda?
I had one point to add to what Uday has said in his red flags. In that red flag, if the patient has given a past history of a malignancy at any stage, even 25 years back, and he says he was successfully treated, I have a very low threshold for asking for an MRI.
Perfect, sir. Yes.
Right, Dr.
My word is that every fracture, even in a defined osteoporotic male or female, should be seen with a suspicion. Unless proven otherwise, it is not a osteoporotic fracture. Investigate till you find the cause, and if you don't find the cause, only then term it osteoporotic fracture.
Right. Dr. Patel, you have done some extensive literature review. Does the world also think like that? Is the world being very defensive and getting more investigations done on day one? Or what's your feeling on that when you looked at literature?
And past history of any fragility fracture like a distal end radius or a hip fracture also is a very important red flag for treating the patient in a more aggressive way.
Right. But what about need for investigations? Is there any algorithm that has been defined in literature that suggests, like in scoliosis, you do MRI if there are 6 points? Similarly here, is there an algorithm to ask for MRI or investigations?
So MRI is to be done because we are going to treat him in a conservative manner right now because he is neurologically normal. But a DEXA scan is the gold standard and it needs to be done if it has not been done in the past.
Right. Fantastic. So over to you, Dr. Peshak Tiwari. You're going to tell us about the 5 most important investigations that you would do in a case that's not getting better at 3 weeks of standardized treatment. You're muted, Dr. Peshak Tiwari. Vishal, you're muted.
Yeah. Can you hear me now?
Yes, very well. And we can see your screen. Okay. Go ahead.
So the 5, I've just made this slide. There's an MRI, there is radiation-based CT and DEXA, scintigraphy-based bone scan and PET. Bone scan is repeated again, and blood investigations. These are the things that would be done in my book for all difficult osteoporotic fractures. MRI is the best one. It picks up all even subclinical fractures that may be there adjacent. It judges the freshness of the fracture, because you will see edema. You will, in a STIR image, you will see any contiguous involvement. It will pick up ligamentous injury. It's also in a chronic fracture picks up. There are a lot of osteoporotic fractures that keep evolving. Like you got an injury on day one, maybe at 3 to 4 weeks, the patient feels a little better, starts doing some more suboptimally treated and this less not braced, and starts activity and again fractures a little bit. So these kind of injuries can be picked up. They're a good predictor of progress, as well as picking up osteoporotic versus malignant vertebral compression fractures. There's a scoring system actually that is devised to differentiate between malignant as well as osteoporotic vertebral fractures. This is the one that has been put up. It's available online. That should be followed so that you can pick up malignant vertebral compression fractures earlier. Well, CT scan gives you a detailed fracture anatomy. It shows retropulsion. It shows involvement. It will show you in an old fracture cortication of the fracture edges. It also gives you a better idea about the bone quality that you are, because an X-ray, especially with the current age of of digital X-rays, exposure is controlled by a software. So you cannot say for sure, looking at a digital X-ray, whether it is bone looks osteoporotic, unlike what we had when we were doing analog X-rays. But now a CT scan will tell you exact idea about the bone architecture and the quality of bone. A PET and bone scan, these are two mainstays when you are also thinking of malignancies. They will show you hotspots, they will show you remote lesions, and of course, multiple level involvement. But the most important thing that everybody should be doing on day one, whether they do an MRI, whether they think a CT scan should be done, all of that is fine. If you have an X-ray, you have a benign looking fracture, there is a certain amount of blood work that you have to do. One of it is, of course, CBC, ASR, CRP to pick up infections. Diabetics are prone to have infections, so an HbA1c is also required. Diabetics are also known to have osteoporosis. So a patient who was, a lot of people get diagnosed in the investigations and then turn out, okay, I had diabetes, that was not checked. When there is multiple level involvement, you should be doing a protein electrophoresis. A very important part of treating is eliciting history, whether there was pain and they fell down or whether they fell down and got pain. This is one thing that is confusing for the patient also. But a lot of patients, if you ask, will say, I had a bit of pain, so I lost my balance, or sat down heavily, and since then it has aggravated. So these are the patients where you need to do serum protein electrophoresis with immunofixation to pick up all the rare gamma globulinopathies. In males, you have to do an PSA, especially when there is multiple lumbar involvement, to check, as Arvind said, for prosthetic issues. Alkaline phosphatase will be raised in chronic, in the first 6 weeks of a fracture. Alkaline phosphatase that remains raised or is raised acutely. If your patient has fallen down today morning and come to you and the alkaline phosphatase is remarkably high, you probably need to investigate whether he has any other reason for this fracture. A serum parathormone, calcium, D3, and creatinine. These are three mainstays to do it. The reason is today we use teriparatide as one of the main treatments in vertebral fragility fractures, because most of the patients who come to us are minus 2.5 or plus on DEXA. The calcium levels and D3, most of common reason for osteoporosis, apart from lack of physical activity, is hypovitaminosis D, low folate levels, and low calcium levels. I have seen a lot of people started on teriparatide without having this basic investigation, because if you have an innately raised parathyroid hormone, which will be so if your vitamin D is low or if you have a renal disease, supplementing teriparatide is not going to help. It's going to cause more problems. You'll end up with a brown streamer-like situation. Also, if a patient has innately low calcium levels and you're supplementing agent to increase bone strength, it will lower it further, giving rise to all the complications that hypocalcemia will have. So these are the things that we have to investigate. DEXA scan, sorry, I've forgotten, that slide is not here. A DEXA scan is also one of the investigations we should be doing for all our suspected fragility fractures. And surprisingly, most of them show a score of -1 or 2 in the lumbar spine. And then you see that, okay, that there are plenty of fractures that do not justify it. You should look at the distal and radius. You should look at the hip, because by design, a DEXA machine is programmed to pick up the most dense structure. And in old people, because of aging of the spine, you're going to have a lot of osteophytes. So they will pick up the density of the osteophyte, which will be dense. So you should look at the hip score and you should look at the distal and radius score to have a fair idea. You'll see a lot of spine DEXAs showing -1 to -2, whereas the distal and radius is -3.8 or 4. So I would rely more on the distal and radius and the hip score than on the spine score when it comes to DEXA scan. DEXA is also a prognosticating tool, in the sense over a period of time, every 2 years when you do one, you know whether your treatment has helped, because the maximum refractures are going to happen in the first 1 to 2 years if you do not treat the main cause, that is weakening of bones.
Thank you so much, Dr. Peshattivar. Can you stop sharing your screen? That is lovely insight on your top 5 investigations. I think most of us would agree with that. At this point, can we ask Dr. Zaveri to tell us what he feels about CT versus MRI scan? Because now this is a new one to most non-exclusive spine surgeons. Would you do a CT scan or an MRI scan, and when? How do you kind of rate it in your head?
So the initial investigation is an MRI scan, because it helps you to you can see much more. You can define, as Vishal beautifully pointed out, acute versus old fractures, helps you to see the ligaments, etc. For me, the CT scan is primarily a pre-operative investigation, and more so if I'm doing a vertebroplasty than if I'm doing an open surgery for stabilization. Because in a vertebral plasty, you need to see the morphology of the vertebral fracture much more deeply in order to judge whether your vertebral cement is going to leak into the disc space in the presence of an end plate fracture, etc. So CT scan to me is a pre-op investigation.
Do it before any intervention. Lovely. Dr. Tikku, can you give us your insight on whether do you think a PET scan can surely differentiate between a malignancy and an infection?
FDG PET scan has got very high sensitivity towards differentiating. I believe it's more than 90%, that it can differentiate and help you where you have some doubt. It can even tell you that what is a suspicious looking fracture on an X-ray, which is involving 2 end plates. Is it a spondylodiscitis or is it a fracture? Versus a malignancy, it can help you to identify the primary source also. But again, nothing is 100%, but it's quite sensitive and quite good investigation to help you guide where you are stuck. And the other thing is that you need to discuss all of this with your nuclear medicine specialist beforehand, so as to let him choose that is he going to do a FDG PET CT or he chooses something else over it, like some radio labeled WBC or something to differentiate. But it's always better to discuss with them and then also correlate with the CT findings. That would even increase the specificity and sensitivity more.
Yes, this question comes specifically because a lot of TB patients have been mistakenly called malignancy, and like Dr. Zaveri points out, even myeloma patients have been mistakenly not picked up on a PET scan. Dr. Vishal Kundani, what do you think about the DEXA scan? Because we as orthopedic surgeons tend to hang our hat on the figure that we see on the DEXA scan. Can you very briefly, as we are really slow on time, tell us what your insight about DEXA? What would you like to tell the general orthopods?
The most controversial investigation is DEXA scan, and yet it's the most useful one. Number one, to understand the severity of osteoporosis. It doesn't help you to only diagnose it. It helps you to understand the severity. If it is -3.5 versus -3, you know what kind of severe osteoporosis you're dealing with, and it also helps you to choose the right kind of drug. Number one. Number two, it not only helps you to choose the kind of drug, but also helps you to monitor the therapy. If at the end of 1 year, one thing is very sure that you got to repeat a DEXA scan. It is one time DEXA has got no meaning. So you got to repeat it at intervals while the patient is being treated medically. And if at the end of 12 months, your repeat DEXA shows a decrease in the value, you know that you are a failing therapy. You got to change your therapy or up your game onto that. And number three, very important point, while you're monitoring the therapy on DEXA scan at 12 monthly DEXA scan, please don't look at those T values, look at the gram per centimeter square values. If the gram per centimeter square values are increasing or at least maintaining, you know that that T-score value is not of so importance to change or maintain a therapy on. So 3 things very important we all must
Fantastic.
follow on.
So just going forward on this case, he was not any better, and at the end of 6 weeks of batting him, he still came back. So we got a dynamic. His MRI didn't show any soft tissue, anything suspicious. There was no posterior element injury either, and his blood works were normal. ESR, CRP, prostate-specific antigen, everything was normal. So we had reason to believe that this was benign osteoporotic fracture, and because he looked like an intra-osseous instability, we thought that he was ideal for vertebroplasty, and we planned him for a vertebroplasty. At this point, we'd like to get Dr. Kulkarni to give us, an insight on whether this planning was correct based on this, the assessment in this guy's case, where you could see the, dynamic X-rays folding up and all other investigations being normal. So, or are there any traps, according to you, which are, designed to trap a surgeon when he plans a vertebroplasty? So I'll stop sharing the screen and hand over to Dr. Kulkarni for his vertebroplasty traps.
Yeah, thank you. Can you hear me, Abhay?
Yes, very much. I can see your screen.
Yeah. So it's very important that you don't become a bakra when you're posting a patient for vertebroplasty. So if you see the graph of a surgeon and his experience with vertebroplasty, it is made up of a continuous series of Ws. You are on top of the mountain one day, and the same kind of fracture pushes you down from the mountain in the very next patient. So it makes you jubilant on one day, and the same kind of fracture, same kind of configuration kicks you out of the window the second day. So it is an enigma, osteoporotic conference fracture, and the treatment itself is also a riddle. So to minimize such kind of happy and unhappy experiences, one can minimize the traps that one can envisage during their career with regards to management of these fractures. So trap one is doing these performing vertebroplasty based on X-rays. Okay, a recent MRI is a must in these patients. Not only is it important to differentiate, so this particular patient here, where my arrow goes, this patient was posted for vertebroplasty based on X-rays. Okay, and when you do the this is another patient where the patient had undergone a fusion earlier, and patient was complaining of back pain, and the X-ray was normal, and the relatives were confused as to what the cause of pain is. And it was only an MRI that picked up this particular fracture. Only then did the lady reveal that she had a trivial injury. So it is important for making a diagnosis. It is important in deciding whether vertebroplasty should be done or not, because fractures could heal. Again, so this is a patient where, on X-ray, there are multiple compression fractures in the upper lumbar region, but that is not where the pain is coming from. If one would go ahead and do vertebroplasty based just on X-rays, you would be doing it at a wrong level. Only an MRI shows that the fracture is at somewhere else totally. And many a times once MRI is done, apart from the primary fracture which is diagnosed on an X-ray, you will identify and recognize that there are additional fracture somewhere else, and that happens with us all the time. And most importantly, it is important to rule out tumor and infection where it will show significant amount of soft tissue. For example, this particular patient, it looks like an innocuous dorsolumbar compression fracture, which we see all the time. Imagine if one would post this patient for vertebroplasty just based on X-ray. This patient revealed loads of pus after doing an MRI. It turned out to be a tuberculosis spine. So MRI is a very, very important investigation. And since osteoporotic fracture and the consequences of this fracture, it's a very it's a very dynamically changing scenario, because these fractures might go into non-union quickly, they might collapse quite quickly. It's very important, or might heal, and by the time you've done an MRI, the fracture would have healed. So it is a very dynamic process. So it is very important to do a very recent MRI before you take a decision. Again, once you have an MRI, again, it is very, very important to have a high index of suspicion to rule out that it's not something else. So this particular patient, you can see some reactionary, changes in the adjacent vertebra here. Again, in this particular patient, it was picked up and reported as a fracture of the inferior end plate of L4, you can see a streak of, pus here and some reaction in the adjacent bone, which made us go back to the, which prompted us to go back to the radiologist and ask them to change the report. So such kind of situation occurs when most commonly when you are a ghost surgeon, someone else has diagnosed a fracture and they want you to come and do vertebroplasty for them. So you should be very, very careful not to get trapped in such situations. Again, it is a myth that kyphosis is directly related in a linear fashion with PLC injury, that is posterior ligamentous complex injury. This particular patient came with this, look at the X-ray and CT scan, you can see the bone density is extremely good in this particular patient. She had a history of trivial trauma at home, and she continued to have pain. Look at the fracture, she shouldn't be having so much pain. So only after doing a MRI and CT did we diagnose that patient has a PLC injury, and the pain was not coming from the compression fracture, the pain was coming from the instability. So we had to fix this particular patient and stabilize her. In case if you miss this kind of PLC injury and go ahead, we are in for a big failure and need for a second surgery, because this particular segment is going to become unstable later on. The process of instability will continue and will call for a second surgery to stabilize the patient. Again, very important in these patients to ask for previous history or current history of claudication pain, especially when the fractures are involving the lower lumbar spine, that is L4, L5, S1, etc. Because these are the levels where the elderly patients have sometimes subclinical undiagnosed stenosis, and the fracture aggravates the situation by compromising the canal dimensions. So it's very important that such things are ruled out, and these patients need not just vertebroplasty, they also need decompression and stabilization. Again, the fracture itself might cause neurological symptoms, and it is very important that that is taken into consideration while taking history and examination, and these fractures are stabilized. Again, this is an epic paper published by today's moderator. So the fracture may not involve the body of the vertebra, it might just involve the superior end plate, and the superior end plate is a layer of loose flakes. And this also leads to significant disc degeneration very quickly because the disc gets its nutrition from the superior end plate. And this can cause significant collapse with time. And if you do vertebroplasty in such a situation, what happens is the cement enters the disc space. There is a disparity in the modulus of elasticity of the cement as well as the superior as well as the bone in the vertebral body above, and this can lead to a fracture at the adjacent level. So this is another trap which one should be careful about, and these kind of fractures again need a stabilization with pedicle screws and rod and fusion. Again, doing vertebroplasty too early, that is a big trap. It is not uncommon to see surgeons doing vertebroplasty as early as within 5 to 6 days. In this particular patient, not only was it done early, but loads and loads of cement were injected to the vertebral body, and that too under general anesthesia. So we didn't have tactile feedback from the patient. Patient ended in paraparesis and incontinence. We had to remove the cement from the extradural as well as the intradural space and stabilize the segment. So what went wrong here? So it was a very short duration. So you need, there always is some degree of comminution of the posterior vertebral wall, and you want that particular fracture to be a bit gummy before you do your vertebroplasty. And also important that the cement lands in the junction of the anterior and posterior 2/3 of the vertebral body. Again, it was not done under general anesthesia. It's very important to do it under local anesthesia, because you don't you want patients' feedback all the time when the cementing is done, so that you are aware of the neurological situation. Again, it's been said again and again, reiterated again and again, that not more than 3 to 5 cc of cement is enough to fill these vertebral defects. Again, the next step is doing it too late. Okay, it's pointless doing vertebroplasty, beyond 8 weeks, because these fractures mostly heal by then. And that point of time, the source of pain is something else. So when they heal with kyphosis. And when they heal with kyphosis, there is strain on the facet joint. So this has been the reason the sham procedure of these NEJM studies, famous NEJM studies, succeeded, because they gave facet block in such situations, which probably took the pain away. So the kind of pain patients have after healing is totally different from the initial acute pain that they have. So in my practice, I look for trends. So there are two types of trends. One is, so you don't have to wait for 6 weeks, 8 weeks to realize that the patient still continues to have pain. So by third or fourth week, you can see, if you ask the patient for a pain scale, they'll tell you that the pain is increasing or the pain is the same and there's no improvement at all. That is probably the right time to treat. The other trend is the trend in the civilization that we have. So most of these are elderly people. They are alone at home, and their sons and daughters, they're all going to work, and these patients want to be up and about. So this is very, very important when you can make their life much more pleasant by going in early and doing a vertebroplasty. Because with time, within 6 to 8 weeks, a fracture which is going to get worse is going to enter a phase of AVN and collapse. And by then the fracture takes a position wherein instead of a benign procedure such as vertebroplasty, they'll end up in a procedure which needs general anesthesia. And you can imagine these patients many of them are unfit for general anesthesia, and also the subsequent wound related complications, ASDs, etc. So in my experience, as well as if you go through this Vertios trial and many other papers, recent papers that have highlighted the critical time, the crucial time when you should do this particularly is about 3 to 6 weeks. I mean, if you look at Vertios 4, probably Ankit will be covering it, you will totally be blown away. Again, once you neglect these fractures and don't do early vertebroplasty, they start dancing and they get deformed in all planes. Of this particular patient, after 10 weeks, we couldn't salvage her with vertebroplasty and had to end up with, doing a long segment fusion. Again, failure to counsel, not only pre-op, post-op also, it is very, very important to counsel. Many of these fractures, because of sagittal imbalance or unknown reasons, tend to collapse, develop late or delayed neurology. So it's very important that you counsel the patient to come back to you if they have any neurological symptoms as early as possible. So lessons learned are, traps that one should escape from are not doing a MRI. So MRI and latest MRI is very, very important. Any kind of neurological involvement needs instrumented fusion with or without decompression. Timing is very, very important. It can make or break a case. And, as discussed, counseling is a continuous process that not only is important pre-operatively, but also post-operatively. And though it is a very benign procedure, you should use it very, very carefully.
Lovely. Thank you so much, Dr. Kulkarni. You really nailed this topic because it's such a hard topic to look for the traps. But while Dr. Arbatti is coming up, to tell us about the procedure and the tips and tricks he uses for vertebroplasty, you can very well see that instead of 5 traps, you already had 8 with a 4A, 4B, etc. So I think all of us know that vertebroplasty is literally, a trap that you walk into. And can Dr. Pawar quickly tell us what his thoughts about vertebroplasty are while Dr. Arbatti is about to share his screen? While you can see this case was, vertebroplasty was done. And, we'll go forward to what happened a little later. Dr. Pawar, what are your thoughts on vertebroplasty as a technique or as a procedure for now?
So it's as we all know, it's a super procedure for those select group of patients. You can't generalize vertebroplasty for all, but those patients within 3 to 6 weeks of time duration who are not getting better, quality of life due to pain is significantly hampered, you definitely get a good result in properly chosen cases. Having said that, I'll be a little bit skeptical in doing vertebroplasty late and just vertebroplasty, especially as I told in a Kummel's lesion. So as per me, it's a great option for those few selected patients.
Thank you. Dr. Arbatti, can you share your screen while I ask Dr. Kundani to tell us, out of 100 osteoporotic fractures that walk into your clinic, how many would end up with a vertebroplasty today?
Today, less than 5.
5 out of 100.
Maybe.
That's a fair figure. Dr. Zaveri, anything different in your
I would agree with everything that has been said. A beautiful presentation by Arvind. What he has emphasized is the patient selection is the key. The procedure comes later on, but patient selection with adequate investigation. One of the additional things I would like to add is that be sure that the patient does not have a bad chest disease. A lot of these patients, there will be micro cement embolism in a otherwise healthy lung. That micro cement embolization will not cause a problem. But if this patient has already got a lung compromise and a vertebroplasty is done, it may just push the patient over the edge, and then the patient may start become respirator dependent. So even that is a very important contraindication to vertebroplasty.
Fantastic. So can we hand over to Dr. Nikhil Arbatti? Go ahead, Nikhil. We can see you and we can hear you.
Yeah. Good evening, everyone. So as Arvind has mentioned, the indications for doing a vertebroplasty. So once you have done all the necessary investigations, once you have decided that the patient falls into that particular time period where you need to do a procedure to reduce his pain, the onus now falls upon you. What procedure should you offer? So vertebroplasty is among the most superb procedures, and I would say among the most simpler procedures to be done. And yeah. So when to do this? So my basic indication when I do this is if it's a almost 4 weeks old fracture, the level between D6 to D7 and L3, basically no vertebra plana and no neurological compromise. Non-indications, no burst fracture, should not be a, if it's a non-osteo, it's a pathological vertebral fracture, if there are neural symptoms, then basically these are non-indications for doing vertebroplasty, as Arvind had mentioned. There are some in-between cases, if it's less than 2 weeks old. Now, Arvind has said that it's very early to do it, but then in some patients, you may have to do it if there is significant immobility and they are non-ambulatory and because of age. So when to do a vertebroplasty, and the other procedure is a kyphoplasty. Basically, if the fracture is more than 70% compressed, I basically prefer to do a kyphoplasty. If it's a 4 weeks old fracture, about 50% body is intact, my preference is to do a vertebroplasty. If there are continuous fractures, two continuous fractures, again, I would prefer to do a vertebroplasty. What are the requirements for doing it? The tips are you require to have a table and a C-arm where you can see your AP and lateral images very clearly. The OT should be in a proper cooling temperature. You can use a J needle, a Jamshedi needle, or Cook's needle, depending upon what is the patient. If he's very thin, you can go for a Jamshedi needle. If the patient is very obese, you can go for a Cook's needle. A dye is an optional which you can use if you want, and a local 2% xylocaine with adrenaline. Something like this, if you see this, the C-arm is able to freely move in an AP and a lateral manner. So this is how the table and the C-arm should be positioned. Now, in a starting, when your patient, usually we do all the vertebroplasties in local, never we do it in a general anesthesia. After you have positioned the patient in a prone position, check the pedicles in an AP and lateral. They should be clearly visible. They should be visible completely like this. Once you have ascertained that the pedicles are clearly seen and the pedicle which is more clearly seen, from there you can take an entry. I usually start with the only unipedicular insertion. I don't do bipedicular because from a unipedicular you can easily insert 3 to 4 ml of vertebroplasty cement. Now the entry should be just about 2 to 3 mm lateral to the lateral part of the pedicle. There you infiltrate with local 2% xylocaine mixed with adrenaline. Once you have infiltrated, about a minute later, you can start with a stab incision and take an entry. Once you have taken an entry with the Jamshedi needle, try docking it over the lateral border of the pedicle. Once you have got a significant good foothold, then you take an AP image, see that where the needle is docked, and in the lateral, it should be in the posterior part of the pedicle. Once you have confirmed this, then you can start advancing the needle, and it should be reaching up to the medial part of the pedicle in the AP and in the posterior part of the vertebral line, posterior vertebral body line in the lateral. When this level is reached in the X-ray, this is in the C-arm. This is the perfect image where you have placed the needle. Anything which is not matching to this, if the needle is more medial, that means you have gone a little bit into the canal. If it is not up to the posterior vertebral line, if it is a little bit behind, that means you have still not gone medially. You can go more medially. just to show you how it is seen in an X-ray image and a video. So basically you need to take multiple shoots, always like a lead appearance. After you have taken the stab knife incision, after the local, with the Jamshedi needle, you can just feel the lateral border of the pedicle. Take an image. Once you have confirmed that you have got a good hold on the lateral border of the pedicle and the AP image in the C-arm confirms it, then you can ask for a lateral image. As you see in the C-arm, it is shown.
Another 10 minutes.
So you require to consult the patient because the patient is totally awake. So
Just 10 15 minutes more. We will tell you, but just be comfortable. Shooting.
So in the lateral, if you see in the C-arm image, it has reached up to the posterior part of the pedicle, and this is where it's properly placed. Now, most of the time, the primary osteoporotic fractures are very, less bone density. You can easily just push the needle in without requiring any hammering or twisting. And as you advance it, you will start feeling that you're entering into the pedicle and then progressing forwards. Now, sometimes you may require, while advancing the needle forwards, to infiltrate a little bit of more local around the pedicle. Yeah. So the final positioning is once you have placed the needle into the anterior 1/3 part of the body, that is where the final position of the needle should be, somewhere here. Now, sometimes in your initial cases, you may take a dye to inject to see if there is any leakage or not, but I usually don't use any dye now. Once you have confirmed the position in the AP and lateral in this way, what you can do is start mixing your cement. And once cement is mixed for about a minute and a half, you can start injecting it. Always take serial X-rays when you're injecting the cement. Make sure that there is no leakage or no extravasation of the cement anteriorly or into the superior part into the disc space. The moment you start feeling that it is leaking, that is when you should stop. In this procedure, you can easily inject 3 to 5 ml of bone cement into it. Kyphoplasty is another procedure. Usually I do it when the compression is more than 50%. You can, what you can say, feel that 3 ml of cement is very difficult to inject. In that cases is when I would suggest to do a kyphoplasty. What you do is you put a balloon after putting in the needle, you inflate the balloon, that creates space, and in that you can easily inject 3 to 4 ml of cement. Something like this, a case, very severe compression, almost it was very difficult to put in a vertebroplasty. After a kyphoplasty, you got about 3 to 4 ml of cement into it. The complications, initial, you may get a reaction to the local. If you're giving plain local, there may be sometimes overdose in your apprehension that the patient is very apprehensive, anxious. A sudden embolus while injecting the cement. There is a cement leakage which can happen, something like this, which you should be totally aware. That's why you should always do it in local, never in GA. The other complications are early adjacent level fracture. If you have injected too much of cement and the load is basically shared to the adjacent vertebra, you can get an adjacent level fracture. A late fracture at the injected level because you have basically bulked up the vertebra. And if there is a fall, then there's a chance that fracture, cemented vertebra can get a fracture again. Yeah, thank you.
Lovely. Thank you so much, Nikhil. You really got all the points together. And while we move on, can I ask Dr. Ram Chedda to give one tip that he would like to share while Nikhil unshares his screen? Nikhil, can you unshare your screen? Can Dr. Ram Chedda share with us one point, if you had to, about about vertebroplasty?
One, since this is a procedure which is done under local, if you have the luxury of using 2 C-arms simultaneously, please do it. It reduces your agony and the agony to the patient. That is one major tip that I share with you. And second, after having done vertebroplasty over the years, please have a low threshold for converting a pure vertebroplasty into a vertebroplasty plus short segment stabilization. That's all.
Fantastic. Lovely tips. Dr. Agnivesh, if you can start sharing your screen, because our patient started doing well with his vertebroplasty, and now he needed some management in terms of medications. So we thought as a group that we should talk about calcium and vitamin D, which is there's so many myths about it, and everyone and their uncles ask us about it. So no one better than Dr. Agnivesh Tikku to address this topic about myths and truths about calcium and vitamin D treatment in osteoporotic fractures. Yes, over to you.
Okay, thank you, Abhay sir. Can you all hear me? Can you see my screen?
Yes, very much.
Okay, so vitamin D and calcium, we all say that give the supplementation, but it's also simple. Is it so simple? So like the American series Mythbusters, we today are going to be the myth BSS tears. So we are going to tear some of the myths which we all hold with respect to vitamin D supplementation and calcium supplementation. So the myth number one is that I take daily morning, evening walk in the sun. My vitamin D should be rocking because I get half an hour exposure morning and half an hour in the evening. The answer to this is that it will not, because there's something called as a solar angle of zenith, which is if it's less than 15 degrees, then only you can make adequate vitamin D. In short, if your shadow is longer than your body, the sunlight will not be able to convert the cholesterol into the vitamin D in your skin. So it's very important that you get the exposure at the right time. The exposure should be around 10 to 15 minutes with your 40% of the body exposed. And there are huge regional and skill color variations. And it doesn't apply to India, but people who live 37 degrees above or below the equator, like North American countries and all, they're in winters, the ultraviolet B penetration is virtually absent. So you cannot make the vitamin D even if you sit whole day in the sun. So this is a very important study, came from our own country, where they took the cholesterol and then exposed it from 8 a.m. to 4 p.m. And the result was that maximum vitamin D formation happens between 11 a.m. and 12 p.m. So it's the daytime sunlight which is more important. Obviously, in the early mornings and all, it's very big. So we need to categorize how much time we spend on the sun during this time. So myth number two is vitamin D is very low. Let me give it a shot. Let me treat it with injection. Injection se jaldi acha ho jayega. So the answer to this again is no. If you see this graph, this dotted is the peroral and this vitamin is the intramuscular. So you can see very clearly that the oral supplementation takes the peak early as compared to an injectable supplement. It's an oil-based injection. It's not going to dissipate immediately into the blood. It's going to slowly dissipate through the muscle, but oral absorption can quickly attain the peak and is better suitable. So again, some contradictions that you give an injection or give a divided dose. Another study proved that orally supplementation is better than injections, and even 6 months oral is still higher numerically, if not statistically significant. Another word of caution with injections is that with injections, the concentration keeps on rising even after 6 weeks time, and it may peak around 3 weeks. Whereas oral, if you give less dose, it starts falling. So you need to adequately titrate the dose. And if you're giving injection, deciding to give injection, do not give 3 or 6 injections. 1 injection is enough. If you're looking at this graph, and if you check at 1.5 months and decide that abhi to kam hai, ek injection aur lagata hu, it's anyways going to keep on rising for the next 3 to 4 months. So do not give 3 or more injections. 1 is sufficient. Recheck after 3 months and then decide what you want to give. Obviously, injectables are preferable in malabsorption syndromes by bariatric surgery, where your oral absorption will be unreliable. Now, myth number 3, activated vitamin D is better. Now, there are a lot of preparations which contain calcitriol or alpha calcidol. So there are very specific indications to use this, like in renal osteodystrophy, to suppress PTH, to treat hypocalcemia because of hypovitaminosis D. And if you have inadvertently given a biphosphonate or a zolindronate in a patient who is deficient in vitamin D and he goes into hypocalcemia, this drug comes to your rescue. But this is not meant to give as a regular drug. It can cause to hypercalcemia, kidney stones, metastatic calcification, and bone loss. You keep on giving a drug containing alpha calcidol to the patient for 3 months, and then he lands up with urologist with a kidney stone, and nobody knows why did that happen. Myth number 4, 10 to 12 weeks, weekly doses is given by me, job is done. The recommended daily allowance is 200 and 400 given in textbooks, children more, elderly even more. But now we have come to understand that in our Indian population, we need around 1,000, minimum 1,000 international units of maintenance therapy after you have proven that your vitamin D has come normal. Otherwise, it will dip down again and again. And then recheck your vitamin D at 3 months. And if required, you can do it at once a year or twice a year as per the patient profile. Myth number 5, calcium tablets. We all say, ek goli subah, ek goli sham ko. So does this hold true? Let me tell you, there are 2 types of calcium formulations which are there in the market. One is the regular calcium base, which contains calcium carbonate or tribasic calcium phosphate. The other are the citrate and maleate one. Whenever you are giving a preparation which contains calcium carbonate, understand these very important points. Calcium needs acidic environment to dissociate. So if you're giving concomitant antacids, proton pump inhibitors, you are reducing the absorption of calcium. Second, not more than 500 to 600 milligram of elemental calcium can get absorbed at one point of time. So if you're giving 1000, the additional benefit of giving that additional 500, maybe just 50 milligrams or 100 milligrams, it's not going to absorb completely. So it's better to space out the dose. Usually the requirement per day in osteoporosis will be around 1000 to 1500 total, including the dietary. So you need to adequately space out the tablet and give it. Food interferes in absorption. So ideally it should be taken 2 hours after the dinner when you are not going to take anything else after that and you're going to sleep. So you sort of acidic environment remains and there's no other food which is going to come after that which can hamper the absorption. All these points can be overcome by the citrate-based preparations which are independent of all these things. And it also prevents the urinary calcium oxalate crystal formation because it binds with oxalate in the intestines and prevents it from absorption. So it doesn't get excreted in urine. The risk of stone formation is also reduced. To summarize, if you're recommending sunlight exposure, recommend it at proper time. Oral formulations are preferable. Do not give calcitriol as routine. Follow-up maintenance therapy is very important and avoid toxicity. Do not give multiple injections. Thank you very much.
Perfect, Agnivesh. This is exactly what we wanted from you. And thank you so much. If you can unshare your screen, we would like the faculty to answer some very common questions that are asked by our patients. So first up, Dr. Peshattivar, your patient tells you that, look, I have renal stones. Can I take the calcium that you prescribed me for my osteoporotic vertebral fracture? How do you manage that?
So they got to be oxalate stones for us to worry about calcium supplementation. It's already Dr. Tiku has given the answer for that. Citrated calcium is better in such cases, but the most important thing is to keep the patient hydrated. Renal stones are formed because of precipitation, because the urine is no longer able to dissolve the solute that it is supposed to dissolve. And that's where the precipitations happen. So if you're drinking adequate water, you are taking care of most of these stones. If you're still a habitual stone thrower, then you need to switch to calcium citrate maleate. That's a better thing.
Would you get a nephro consult on this, or would you just manage this yourself?
So recently, one of the cardiologists just stopped one of my severely osteoporotic patient from taking any form of calcium because she was forming intravascular calcium deposits and she had already got a whole tree of stents in her heart. So there is no common ground. There is one paper which supports and one paper which goes away. What I think is we should more concentrate on having proper vitamin D and folate levels, which are essential for absorbing calcium from the diet.
Lovely. So the orthopedic mantra is often wrong, but never in doubt. So we should do what we think is right. Dr. Ankit Patel, my patient says that I get constipation every time I eat your calcium tablet. How can I manage this?
So first of all, I'll ask him whether he had a past history of constipation and whether it has been aggravated by the calcium what he's taking. I like to check whether it is a carbonate kind of a drug or is it a citrate maleate kind of a drug, because the carbonate has a more propensity for constipation. I'll ask him to take more dietary fiber and water, and ask him to take the calcium tablets on an empty stomach. If this solves this problem, it is okay. Otherwise, he'll have to have a calcium-free period interval and then see if the constipation resolves.
Right. Dr. Ram Chedda, इतने सारे कैल्शियम अवेलेबल है मार्केट में, आप बेस्ट वाला मुझे दो, पैसे की कोई चिंता नहीं है.
Well, I'll first correct his vitamin D3, which is very, very important. And if I have to choose one calcium, I'd go with calcium citrate maleate.
Right, fantastic. So I think we heard it from Agnivesh. Do you want to add something to the discussion so far? Because we had curtailed your talk to 5 minutes, but you have a lot of information and knowledge on this. Agnivesh, Uday, anyone else wants to say something? Nikhil?
So I just want to know, I mean, how many of you go for the type of formulations to give the patients calcium, or you just prescribe the brand? I mean, how does it go? Because, I mean, does everyone look for a calcium citrate maleate? What it is when you're prescribing?
What do you do, Dr. Arbati? What do you do?
So I go by the brand, and I actually haven't had any patient complaining of renal stones after starting the calcium supplement. I mean, they usually complain before that they have past history.
Yeah, I mean, calcium and vitamin D, all the GP, the family doctor, the patient's relatives, everybody gives so much of calcium. So we run the risk of vitamin D. So more than checking this thing, we should check the values, and if at all in a case where there is they are not going to absorb carbonate well, shift to maleate.
Dr. Tiku, what's your thought about these combinations with 500 calcium and 10 micrograms of vitamin D? Does it work, or is it just a marketing gimmick?
I think, sir, it's more of a marketing gimmick. They say that that amount of vitamin D will help in absorption of calcium, but actually we all know that vitamin D needs to undergo activation in liver and then in kidney, and then only it can start acting. So after that, it will go to the intestine, transcribe the DNA, mRNA, translation. So all this cannot happen within those, say, 3 or 4 hours where it is going to be. So it's
fantastic. Thank you so much. So as you see, coming back to our patient, he took his calcium, took his vitamin D, but he was doing badly after an initial good result. Like many of them do, this guy started to go bad, and at 6 weeks, the X-ray showed an erosion of the end plate across the other bone. And of course, at that time we said, oh, we should have managed the osteoporosis. Now there are pills and promises and prayers and injections that are available, and we have none less than Dr. Vishal Kundnani to tell us about really what an orthopedic surgeon needs to know about osteoporosis management. At this point, I must tell you why we've got Vishal to talk about this for 2 really big reasons. One is that he's Vishal and he knows everything about this. But more importantly, we as orthopedic surgeons who are treating these fractures need to take charge of this treatment, and we cannot assign it to endocrinologists or physicians because they do not have the pulse of the patient's complaints, and they are not going to be facing the music if the fracture starts to go the way my patient's fracture is gone. And hence we need to be ultra aggressive, otherwise we end up losing a wicket there. So if anyone in the faculty has something to say, Ram is smiling, Gautam is silent. If you all have anything to say, else we let Vishal take over.
No, Vishal should take over. I'm just smiling at the photograph of Vishal that you've chosen.
Okay, so this will be discussed in the after hours.
Even Vishal was smiling.
Over to you, Vishal.
What we rightly have discussed here is that after steroids, the most commonly misused medicines in orthopedics are calcium and vitamin D, and all these get magnified by at least 100 times when it comes to treatment of osteoporosis. And all these drugs not only lead to medical mismanagement, but also lead to a recipe in making with disasters in making with osteoporotic fractures there. And invariably, we all believe that osteoporotic fractures of this kind will heal better only if we treat them only with a particular kind of drug like a teriparatide or something. And in late times, with the new kid on the block like denosumab, more and more misuse of all these medicines is going to happen. And today, by these 5 minutes, I'm going to deliver just 10 messages, which are from here onwards going to be the final verdict rules of medical management in osteoporosis. Like in this particular patient with the osteoporotic fracture, where all the other things were ruled out, what we have discussed in the line, all the red flags were taken care of, and now this patient needs medical management. Unfortunately, when it comes to medical management, we are far more confused than we are when it comes to surgical management. And questions like these: when to start immediately as the fracture is seen, or wait for a few days, as it is said that bisphosphonates started early in the course of disease can lead to...
We can't see your screen.
Is it?
I am not able to...
Yeah, we are not seeing your screen.
Okay, let me just reshare, sir. Just give me 1 minute.
I thought you were hiding everything and giving us a suspense story.
Yeah, here you are. We can see it now. Go ahead.
So when the medical management is the question, as I said, it's far more number of dilemmas come across and confusions come across of when to start, what kind of medicine to start with, how do they work, Is DEXA scan the way to start, or we have to only use it for monitoring? Do we use combination of therapy, or solo therapy works well and good as combination? And what combination of medicines? How long do we give each drug? When to start which one, when to end which one, for how long can we have exposure of a particular drug, and how do we monitor these? While monitoring them, when do we call that the therapy is failing? And all these questions and much more today. The unfortunate part of osteoporotic medical management is that, one, we know the least of all these medications, and unfortunately the problem is of plenty, that we have so many options of which we know so much of nothing about. And today probably in these some slides we'll get to know something about all of these. We must remember certain rules, and the first and foremost rule of osteoporotic fracture management, be it hip fracture, radius fracture, or spine fracture, is that the best fracture prevention option is general care. It is not medication. It is nothing but to build the overall wellness of the patient and prevent another second fall. Remember, it is said that one fall of the patient which has resulted into hip and spine fracture makes a patient prone to have a second fall within 2 years of time, and that's where we have to target maximum. And if you can have prevention of fall modalities being described not only to the patient but also to relatives, to make arrangements in the bedroom, get their washrooms dry when they sleep, have a night lamp, have the lights on in the bathroom, and correct eyesight, correct BP medication, all these things can really make a big difference, and you can reduce the second fracture in these patients. This is the best prevention modality for any patient with osteoporotic fracture. This is something that we all must target upon, and this is the most effective way to prevent the second fracture in these patients. About medication, start the earliest is the rule. When do you start it? In every patient who comes to your clinic, you must screen them clinically. If they have a risk factor, start it as early as possible. Don't wait for the treatment to be started only when a fracture happens in them. You can start these things, these medication at the earliest as the patient comes to you. So every patient should be screened in terms of history taking to ask for any secondary factors of osteoporosis, any patient with hypocalcemia in your regular blood checks, or any patient with menopause 5 or more than, or any patient with a past history of osteoporotic fracture. You should take a chance to start treating them with medical treatment, and please don't wait for fracture to come. Remember, general care is the first thing that you get neglected, and second is we often tend to start these medication too late when already the bone bank has been completely depleted, and this can be done only when we have a very aggressive approach to prevent first fracture rather than preventing the second fracture in treatment of osteoporotic fractures. The third thing, remember, all these medications that are available to our disposal, they are not to be misused. Remember, all these medicines have a certain rule to follow. You just cannot take up teriparatide and start in any patient. You just cannot just jump onto a denosumab, or you cannot just start bisphosphonates in every patient. There is no way you can treat these patients empirically by just starting any medication at any point in time. Remember, baseline workup is mandatory. Like Dr. Arvind mentioned, like Dr. Vishal Peshetiwar mentioned, a baseline workup is absolutely mandatory to start and to understand that these medicines will work optimally only in those patients who have a feasibility check whether these medicines are going to work in a positive manner or in a negative manner. Why do I say so? Is because all these medicines, whether they are anti-resorptives, anabolics, or denosumab, or any medicine, they are all known to reduce the calcium levels in your body. They are all known to create sarcopenia, and that's why you got to be very, very importantly checking whether they have a high bone turnover to begin with. A parathyroid hormone cannot be started in a patient with high alkaline phosphatase. It cannot be started in a patient with low calcium levels. Bisphosphonates are known to create hypocalcemia. So if you start a bisphosphonate or a teriparatide in any of these patients with already high parathyroid hormone level or already low calcium levels, you're going to create a disaster. A patient with creatinine levels which are altered, asthma or gastric issues, you're going to be making a bigger problem to deal with if you're taking care of these patients in a very absurd manner. And remember, when you are treating these patients, it's your duty to not only monitor their calcium level monthly, but at least at as frequent as you can to check if the calcium levels are going down, to understand whether the failure of therapy is happening. So no empirical treatment is the rule when you're starting any of these patients with.
Vishal, you have half a minute left.
Anti-resorptives are the first line of treatment. Prevent bone resorption is the first thing. Reduce osteoclast function. Do not form the new bone. Remember, anti-resorptives are the first line of treatment. The moment you see these patients, you have various options of bisphosphonates and denosumab available. Remember, anti-resorptives are the first things to be started with. Bisphosphonates, yes, they are the primary treatment of choice, and these are the primary drugs that you should be using. How do they work? They reduce the bone resorption, and that's how the architecture of the bone starts improving. But remember, they have to be avoided to be used in acute fractures. They can lead to high rates of non-union, should not be used in young patients, and always do a feasibility check when you're starting a bisphosphonate. As we just mentioned, denosumab is another anti-resorptive drug which prevents bone resorption. And remember, it also works in the way bisphosphonates work. However, they have to be primarily used in those patients where bisphosphonates are either contraindicated or they have already been used for a very, very long period of time. Also, in a maintenance therapy, when you have already finished the exposure to parathyroid hormone, or also you have finished the exposure to bisphosphonates, denosumab comes very, very handy in those patients. They increase the bone strength as early as by 6 months, and that is why you should wait for at least 6 months to understand whether you want to change the therapy or not. Ideally, for not more than 12 months, and that's when you should do a BMD scan at. Teriparatide is the new block. We all know that it enhances skeletal architecture by stimulating osteoblasts. They have to be given in a daily manner by 200 micron daily dose, and their injection route is subcutaneous, to be given never more than 24 months, but not less than 18 months is something recommended. However, caution should be used in patients with low serum calcium or parathyroid hormone, and that's why an absolute feasibility check should be done whether these patients can be given teriparatide or not. And this is something that has led to more problems with teriparatide than anything else. How do we give them? They are extremely efficacious. We must remember that asymptomatic patients start with bisphosphonates on a weekly basis, something that is recommended more than daily or a yearly basis. Fracture with a minus 3.5 or any patient with a fracture in spine, you should start with teriparatide, and bisphosphonates can then be taken over as a combination therapy. Denosumab can then be started only after as a maintenance therapy or when the bisphosphonates are contraindicated in these patients. How long do we give? Bisphosphonates can be given for up to 5 years, but not more than 5 years is what is recommended. However, minimum therapy is for 24 months. Teriparatide should not be given for more than 24 months. Denosumab can be used as a maintenance for lifelong therapy at 6 monthly interval. And this is what is recommended. As we all know, osteoporosis is an ongoing process, and we have to continue treating them medically as well. How do we monitor therapy? We know that the side effects can be monitored by monitoring serum calcium at every 6 weekly. Ideally, you should do it every 6 weeks time. Also do alkaline phosphatase. Bone markers can be done only when you are using anabolic agents, and BMD should be repeated at 1 yearly interval. It is recommended that combined therapy is better than a solo therapy, and that's why you should understand the superior results have been obtained by combined therapy using bisphosphonates and anabolics rather than only monotherapy with bisphosphonates alone. When do we call it a failure? If you see a BMD going down even at 1 year of therapy, or if you see a new fragility fracture on treatment, this is one thing when you should understand that your therapy is failing and you may want to change your therapy. However, for every failing therapy, you must also try to find out what is the risk multiplier. Are there risk factors which we have neglected, or there is a lack of adherence to any one particular kind of drug? So to summarize, medical management of osteoporosis should not be empirical. There are certain rules to follow. Fractures do heal well if you treat them medically. And remember, general care and follow-up prevention is also as important as medical management of these patients. Thank you so much.
Thank you so much, Vishal. You really covered a difficult topic quickly, and I'm sure there'll be more discussion on this. Before that, can Gautam unmute himself and tell us, Dr. Zaveri, in which situation would you look to start with teriparatide on day 0?
So in any patient, as Vishal very rightly mentioned, is a patient with severe osteoporosis where there is a patient who has a DEXA score of -3 or more or less rather, and who has multiple fractures or a past history of another fragility fracture elsewhere, and now has developed an osteoporotic vertebral fracture. These are the patients in which also in patients who are on glucocorticoids or steroids for other conditions. These patients, the response to teriparatide is far better than with other. Diabetics, high diabetics where osteoporosis is very common is another case where I like to start teriparatide early.
Lovely. And Dr. Kulkarni, can you give a very quick summary between bisphosphonates and denosumab in your head? How does it pan out?
Yeah. So I'll, my opinion would be about my experience. So there are papers which show that together synergistically they work very well, both of them together. So in patients who have I don't do DEXA, I do a QCT, and I see very bad T scores of -4.5, -5, etc. So if it is beyond -3.5, I use a combination of both bisphosphonates and denosumab based on these papers, and I've seen good results. Good results is all the feel that you have with the patients. And my experience with both these agents have been very good when there has been loosening of implants post-operatively, and especially denosumab when the patient has come with a GCT or a ABC has come back with a recurrence.
All right.
It is
Thank
out
you
of
so much.
topic here, Arvind, but I have a question here for Vishal Abhay, if you don't mind.
Yes, please.
And that is that if there is a fresh osteoporotic vertebral fracture, should you start this patient on teriparatide, or is it safe to start bisphosphonates in the acute setting?
So it's a very important question. Actually, in fact, what has been mentioned is that bisphosphonates should not be started in acute fracture setting for at least the time when the fracture has become sticky. Early bone resorption not only is a part of fracture healing process, and bisphosphonates only increase this process of fracture resorption. And that is why it is recommended that bisphosphonates are not the primary drugs to be started in a setting of acute fracture. However, it has been noted that in a patient who has had a fracture 3 weeks down the line, the fracture healing happens better when bisphosphonates have been added later in the course of treatment. So early fractures
That's
surely
important
not.
points, Vishal. Very important point. Thank you so much. So now, if you see, our patient started going downhill, and things started going south after the first few weeks of improvement after V-plasty. He became unstable at the disc vertebral level. We tried to bat him out. We gave him all the medical therapy that we had at hand at that time, but he started going worse, and eventually we couldn't bat him out because he now started developing neurology, and we had to go in and do this kind of an operation. You may call it good, bad, ugly, whatever you like. I'm putting it out there. He had a good early neurological recovery. We just did a transpedicular posterior decompression and fixation because we felt that instability was his main problem, because his neurology was normal in bed, but as soon as he loaded up, his legs were giving way. But at 2 months, this short construct, which looked pretty doomed on day one, started to fail. Once again, we tried to brace him, give him extension exercises. We gave him the best available medication at that time. But finally, that screw in L2, in the L2 vertebral body, started digging on the nerve root, and he started coming with a radicular deficit, and that could no longer be L3 nerve root. It could no longer be withheld. And at this point, we were really stuck because we had 2 goes at him: one failed vertebroplasty and one failed surgery. And what next? So obviously, I think all of us have had these problems with bad bones. The wicket that you're batting on is a bad wicket, and hence we need to be aware of what all tips as a surgeon you'd like to have in your armamentarium. And for that, I'd like to invite Master Surgeon Dr. Ram Chedda to give us tips on how to handle osteoporotic vertebral fractures as a surgeon. Over to you, Ram. You're muted, Ram. You're muted. We can see your screen, but you're muted.
Can you hear me now?
Yes, pretty much.
Great. Okay. I'm going to talk of 5 tips for surgery in severely osteoporotic spine. Whenever we do any surgery for any particular part of the human skeleton, there is a purpose involved, why we do it, and there's an expertise involved based on what evidence says and what our experience is. The purpose of why we do something depends on the use of how and what, the process and the product. And our final expertise is the delivery, depends on the evidence and the experience. In osteoporotic vertebral fractures, the purpose may be taking care of the pain, taking care of the instability, taking care of the neurology, taking care of the deformity, or all the above compounded by severe osteoporosis. What are the challenges that we face? And that depends on our expertise, where we combine experience and evidence. 1, such patients can have a high index of mortality due to anesthesia unfitness or embolism. There could be early morbidity. Despite a procedure, there may be residual pain, recurrent pain or neurology, or a late morbidity where fresh pain comes in, a relapse in pain, a different level gets painful, late neurology, worsening of deformity despite implants, adjacent segment issues, and implant related issues. The 5 common surgeries done: percutaneous cement augmentation, posterior stabilization with indirect decompression, posterior decompression with stabilization in situ, posterior decompression, stabilization, and anterior reconstruction, and a salvage. Let's go one by one. Posterior percutaneous cement augmentation, posterior stabilization, incomplete or you have not done a decompression, so it's an indirect decompression. This is a decompression with an in situ stabilization. This is a long construct with a decompression and a stabilization and an anterior reconstruction with cement. And this is a salvage where nothing else worked. Let's look at the 5 tips per procedure. I delay my cement augmentation. As Vishal said, 5 out of 100 patients require vertebroplasty. We make that 5 into 4, 3 and 2 if possible, delaying them up to even 6 weeks if possible, till they become subacute and painful. Always under local anesthesia, prone position, asepsis in the OT. I take a linear incision, not a cross incision. I prefer 2 image intensifiers. Whether I'm going uniportal or biportal depends on the actual CT or MRI telling me whether my Kummel's lesion or fluid cleft is mainly on one side or on both sides. A lot of the volume of fluid aspirated, 3 to 5 ml, helps me decide how much of cement I'm going to inject. This fluid is sent for an FNAC. I always put cement in a semi-solid erectile phase with a 2 ml syringe with a lure lock which fits onto the Jamshedi needle. This is how I place my 2 C-arms. I am very unhappy going up and down with my C-arm within a limited constraint of time with the patient under local anesthesia with cement setting. Once I'm put at the injection, I inject my local. This helps me decide whether I'm going uniportal or biportal. If biportal, both my needles will go in exactly the way Uday told us how it is done and Nikhil told us later. This is the erectile phase of the cement where it is not falling down but is like toothpaste and going into the opposite direction. I use 2 ml syringes to go in. Some people prefer 1 ml. I prefer 2 because 1 ml actually goes right into the needle itself. And then we have to remove the stillet and push the rest of the 1 ml with the stillet all the way in. I have 2 image intensifiers working simultaneously, giving me biplanar imaging all the time. This is the way I do it. Now let's move to the next procedure, posterior stabilization with indirect decompression. This is usually percutaneous, 1 to 3 level screws above and below. Screws should be of maximum length, maximum diameter, variable screw head, ideally HA coated or cemented or fenestrated. Do a strategic screw placement. They need not necessarily be parallel. They could be multi-directional. Try and make them bicortical. Always under tap them. Use titanium screws. Have a low threshold for adding percutaneous cement augmentation, either at the level that is osteoporotic or at adjacent levels to strengthen the construct. You may use non-ionic contrast for a myelogram, iohexol, if you are doubtful of your auto decompression. I have done this if I'm not sure whether my patient who had incomplete neurology, who was getting neurological on sitting, but was having no neurology when lying down, whether he has actually been auto decompressed, I could use a non-contrast ionic myelogram effect. Let's talk of posterior stabilization with indirect decompression. As I told you, I usually identify the Kummel's lesion. This is a lady who had a low back surgery done by me about 17 years earlier. Came back, I put in my screw, I put in my cement percutaneously, and I also put in my 4 screws above and below. As I said, I now have a low threshold for putting percutaneous screws in addition to doing an augmented stabilization from the rear. Posterior decompression with stabilization in situ. This is an open procedure. It's usually long, occasionally short, but there is a construct to be in situ. I do not aim to correct the deformity. In fact, I'm happy under correcting the deformity. I do a posterior open decompression. I do a biopsy or a frozen section. I have a low threshold for adding cement if I have to reconstruct the anterior and middle column. And I may add a transverse connector and do facet fusion, which is because I've gone open there. This is to show you a lady who came, who presented late. We kept treating her non-surgically. She kept worsening. And then she developed a neurology which needed an open surgery from the rear. And she had pain. So we did a posterior decompression with a stabilization in situ. This is a late X-ray where she's showing fusion across from the lower vertebra going across to the other. There was a non-fusion earlier because of the instability that was occurring there. So this just needed a stabilization. Let's move to the next, which is the even more difficult situation where there's established neurology. Here you need a posterior decompression stabilization and somehow an anterior reconstruction. This is usually a long posterior construct. What I prefer today is a posterior column shortening to reduce the anterior void completely if possible. For residual anterior void, I may use a little bit of cement or sometimes a titanium or a PEEK spacer. I try and avoid the anterior transthoracic diaphragmatic retrocranial approaches, which I used to do very aggressively earlier. I use hybrid augments like hooks and screws in addition to supplement the rods. This is what you will see. You will be surprised the amount of correction that I got by just doing a posterior in situ stabilization. So this patient needed an anterior surgery. So this was something which I used to do earlier, a back and front. Now what do? If I have a situation like this, I go only from the rear and I do a posterior shortening, posterior column shortening from the rear. And if necessary, as I'm showing here, I may do a posterior column shortening with a little bit of cement augmentation in the front. That is how I felt when I did these back and front surgeries, unhappy in the long run. And this is how I feel very happy now when I'm doing a posterior shortening with maybe a little bit of cement added in the front. What is the salvage? Well, there are long constructs that you can use in very severely osteoporotic patients when nothing can be held. Please remember that the lamina is still good enough. It's still stronger than the pedicle and the vertebral body. So you can use wires there. Yes, they are stainless steel. You should, in such patients where you're doing a heart shield, in these patients, be very, very careful when you're removing those spinous processes. Don't weaken the central part because your wires will cut through the center. So leave a stub of the spinous process. Please remember, sublaminar wires are delivered bilaterally without damaging the laminar edges. You cannot afford to touch the laminar edge. Just work interlaminar throughout. Have a high threshold for cement. And remember that despite this posterior construct and a little bit of cement in the front, it will still allow some micro motion and settling. So it's an excellent procedure when you're doing it for a salvage. Remember, it's an internal brace and all these patients need to be supported with an external orthotic device for 3 to 4 months, especially those where you've used sublaminar wires. What are the other ways that I used? Well, I used to do cement augmented screws. I still use them. I do percute screws and I cement and augment bodies which are above and below in addition so that I don't cause adjacent level disease. But in severe situations where nothing else is working, where you've tried to put in one pedicle screws and it is like butter, in those patients, you will have to go back to the old conventional heart shield ring with sublaminar wires. And believe me, gentlemen, it works and works very, very well. So my final message, subacute painful situation, I say 6 weeks, some people do it 4 to 6 weeks, vertebroplasty, dynamic instability with postural neurology, posterior stabilization with indirect decompression, you don't need to open the canal, instability with neurology due to mechanical compression confirmed with CT, MR, posterior decompression with stabilization in situ, instability with neurology with deformity, posterior decompression stabilization with anterior reconstruction, try and do it all from posterior, either a shortening posterior column or a little bit of cement or maybe a spacer. I try and avoid the spacer as far as possible. Unstable osteoporotic vertebral compression fracture with screw hold suboptimal due to severe osteoporosis. Go back to your salvage, stainless steel ring with sublaminar wires. Thank you very, very much for a patient hearing. And I hope and pray that all our patients live long enough to celebrate 104 years and see you there when they are celebrating it. Thank you very much for a patient hearing. That's my team that I work with, and I'm most grateful to them for having participated in this presentation. Thank you so much.
Lovely. Thank you so much, Ram, because that was a very, very comprehensive review. And since we are a bit stuck on time, I'm going to quickly show you what we did. We followed your rules. We followed your advice. And in this failing case of osteoporotic vertebral fracture, the third time around, this is what we did. And pretty much like you said, we played to the strengths of this spine rather than the weaknesses. And that is how we got away in the end. So we still need to know whether what we're doing is correct or not. And hence to round up what's the latest or what is hot off the pan in the literature department, we have Dr. Ankit Patel, a young Turk from Bombay, who's going to tell us about what is that 5 messages in literature in the last 1 year on osteoporotic vertebral fractures. Over to you, Ankit. I'm going to stop sharing my screen. Go ahead, Ankit.
So quickly going around with the review. So we all know that WHO has defined osteoporosis as a disease with a T-score of -2.5. So we all should be mindful that there is a big treatment gap when it comes to osteoporosis. When it comes to myocardial infarction, we all know that every patient after an MI gets a beta blocker and an aspirin. But when it comes to osteoporosis, very few or probably less than 20% even receive any therapy to reduce the future risk of any fracture. And the causes for this is over-reliance on calcium and vitamin D combination, lack of awareness, and the cost of treatment, and especially the fear of side effects with bisphosphonates. So what is new in diagnostics? We all know that DEXA scan is the gold standard, but what is the preferred site for bone mineral density monitoring? And what is the indicator of treatment-related anti-fracture effect in routine? Treatment-related increases in bone density, and spine BMD change is not an independently associated with the fracture risk. What are the other modalities which are available when it comes to monitoring of the bone architecture? Compared to DEXA, QCT, trabecular bone score, and peripheral USG are the 3 other modalities which are available and can be used. Quantitative CT and MRI allow bone score, which measures the texture in terms of grayscale levels of any X-ray or an DXA image, is also useful. A combined trabecular bone score plus a DEXA scan was superior to either of the measurement which was done alone. And especially in terms of spine osteoporosis management, it can predict an osteoporotic fracture beforehand. Coming to the medical management, we all know that teriparatide and alendronate are the frontline drugs when it comes to treatment of postmenopausal osteoporosis. But in terms of spine, the teriparatide has been shown to be superior to alendronate in terms of increasing the lumbar spine BMD. A combination therapy has an advantage of 36% in terms of fracture risk reduction, and the improvement in lumbar spine BMD is even better when you use a combination therapy, most typically a teriparatide with alendronate. Recently, especially in Japan and Korea, weekly or bi-weekly teriparatide has been made available by the FDA. The rationale here behind is improved compliance and lesser side effects. So both of these modalities, either a weekly teriparatide in terms of 56.5 micrograms once a week or a bi-weekly teriparatide in terms of 28.2 micrograms twice a week, have shown to be equally and sometimes even more effective than a daily dosage. The adverse drug reactions have seen to be a bit less, and the compliance is better. So these are the recommendations, level A recommendations by the AOS, which has been recently published in the JBGS, wherein lifestyle modifications such as exercising and stoppage of addictions like alcoholism, excessive smoking, or sedentary lifestyle is given importance. Laboratory testing and fracture risk assessment using the FRAC score also is given importance. Bisphosphonate teriparatide have to be given in a combination if the score is quite significantly low. Calcitonin has been shown to reduce fracture-related pain, but there is no direct correlation in terms of improving the bone marrow density. Estrogen therapy should be given in postmenopausal females. Denosumab is having no primary role as such in management of osteoporosis, but definitely it is having a role in terms of managing when you are switching over or using a crossover therapy. So how do you monitor response and compliance? We have been very seriously lacking in terms of using the bone tumor markers. Ideally, every patient who is being started up on teriparatide should get a P1NP level done before starting, and then every 3 months, because it is the most sensitive marker, and it can be used to see how there is a response to therapy, as well as how well the compliance is. In terms of patient who is on who is a known chronic kidney disease, the blood markers and the urine markers cannot be used, and a bone specific alkaline phosphatase and a PTH is recommended. in terms of biphosphonates, when you are using biphosphonates for long term, a predictor of long term side effects can be predicted, especially when you are fearful of osteonecrosis of jaw and atypical femur fractures, by using the resorption markers which are X and P1NP.
Ankit,
When you have
summarizing, please, last concluding slide.
Okay, so to move, when there is a concept of drug holidays, theoretically and literature wise, the drug holidays concept is not supported by evidence, because there is a risk of fracture and loss of bone strength. When you stop denosumab, you have to give alternative drug, because there is a proven reversal of drug effect when you stop denosumab after long-term therapy. Vertebroplasty and kyphoplasty have stood the test of time. So in terms of long-term outcomes, vertebral augmentation has shown to be giving better outcomes with a better morbidity, reduction in morbidity, especially 22% when seen in years. So we should be mindful of the osteoporosis treatment gap. A hip BMD score is a better tool for monitoring the response. Trabecular bone score or QCT can be used in conjunction with DEXA. Combination therapy is the future. Alternative regimens of therapy might become the mainstream in the coming years. Monitoring of compliance using the bone tumor markers is essential, and identifying the risk factors, especially for non-union when you are treating conservatively, should be done. Thank you.
Thank you very much,
Ankit. You were right on the ball, and thank you for getting all this together. So just the conclusion, and I'll invite the very knowledgeable Dr. Gautam Zaveri to conclude the session. But if you had to learn one thing from this, it's the line in red that our sponsors are going to be very, very happy with, because Intas are sponsors for today. They make Olimab and they make Terifrac. Both are the drugs that we use extensively in anti-osteoporotic treatment. So remember that all your OVCFs come with two problems, a fracture and a medical disease. You got to treat both of them if you're a good doctor. And with that, may I hand over proceedings back to Dr. Gautam Zaveri, who will then round up this session and conclude for the day. Gautam?
Yeah, so I'm just trying to share my screen. So as Abhay just mentioned, and this beautiful webinar, most of the people who have mentioned this have already talked about this, and that is fragility fractures, that is osteoporotic vertebral fractures, are a mechanical consequence of a biological disease. The biological disease being osteoporosis, which needs to be treated. We all know about the epidemiology. We know that the incidence increases with age. We know that if you've had a previous vertebral fracture, then the risk of a subsequent vertebral fracture increases. If your vertebral fracture previously was a severe fracture, again the risk of a new fracture increases significantly. The clinical consequences, as were mentioned, are pain, loss of mobility and function. In about 3% of patients, there is neurologic deficit and, of course, spinal deformity. But what is not mentioned is the clinical consequence is death. There is an 8.56-fold increase risk of dying within 1 year after a spinal osteoporotic vertebral fracture in the elderly as compared to patients who had no fracture. We must, when people have talked about the decision-making algorithm, well, step one, if an elderly patient with back pain after a domestic fall comes to your clinic and he has tenderness pressure over the spinous processes, remember that this patient needs to be investigated, because in these elderly patients, degenerative condition, osteoporotic vertebral fractures, infection, metastasis, and multiple myeloma are the differentials. So what one starts with, as all the panelists have said, is that on day one, they would like to get an X-ray, get an appropriate thoracolumbar spine AP and lateral, and of course, do all the blood tests that Vishal mentioned rightly, except that he did not talk about thyroid function, and you must add that to it. Once you have confirmed that there is a vertebral fracture and there are no other warning signs, what are the warning signs? If there has been no history of a trauma or a fall, there has been a history of fever, weight loss, anorexia, there has been a past history of cancer at any point, a tuberculosis, a fracture which is above D7, which is the stable area of the rib cage, and X-ray evidence of infection or tumor, which means reduction in disc space, osteolysis within the vertebral body. All these are warning signs. Here, if you do not have any of these, you can start non-operative treatment. Non-operative treatment, short period of bed rest till severe pain goes down. Analgesia has to be very well controlled because gabapentin, tramadol, Ultrasec cause increased giddiness, increased risk of fall. Also remember that you have to give other drugs like calcitonin, which may help in pain relief. As Vishal mentioned, osteoporosis treatment is multifocal, high protein diet. It means exercise and it means anti-osteoporotic treatment besides calcium and vitamin D. Low impact aerobic exercises when possible and weight training have to be started at some point. Bracing, there have been different varying opinions. My personal opinion is bracing doesn't work too well with these patients. You give them a hyperextension brace. These patients have a facetal arthropathy. They end up having more pain. Most of the patients don't like the weight of a brace and they don't like to be pushed into extension. So I don't use bracing routinely. The natural history is very important. If you have 100 patients with osteoporosis, 63% of these will go on to normal healing within a period of 6 to 8 weeks. About 35% will have progressive collapse, but of this, more than half will heal in a collapsed position. Collapse is normal. Don't be worried about collapse. Collapse is to be worried when either it causes significant deformity or it results in a neurologic deficit. Otherwise, even a young patient who is treated for a thoracolumbar fracture non-operatively will have an X amount of collapse. Collapse is body's way of healing the fracture and assuring stability. About 14% will develop a Kummel's lesion, a pseudoarthrosis. A small number of them will develop a neurologic deficit. In 2/3 of the patients, pain reduces by more than 80% within 4 to 6 weeks of injury. As Ram said, 6 weeks is worth waiting for in order to try and get relief of pain. Beware of delayed collapse. The fractures which have a delayed collapse are burst fractures, those where there is a Kummel's lesion, and those with ligamentous instability. Step 3, if there are warning signs, if there is a primary neurologic deficit, if patient is complaining of increasing pain, ideally patient's pain, as Vishal said, should reduce over time. If the pain increases or the nature of pain changes, then be suspicious and get an MRI scan. If primarily the X-ray MRI shows evidence of infection or malignancy, treat appropriately. If MRI confirms a painful vertebral fracture, not responsive to non-operative treatment within 4 to 6 weeks, no neurologic deficit, and no significant deformity or intervertebral instability, that is ligamentous instability, then vertebroplasty, kyphoplasty, vesselloplasty, these are all percutaneous techniques which are very useful. Vertebroplasty and kyphoplasty are both useful. There is a lack of time, so I'm not going to go into details of this. When should you not do a vertebroplasty? That is more important. If it is an asymptomatic compression fracture you have just picked up on X-ray, if it is an AO type B or C fracture where there is ligamentous disruption, if on your sitting standing images you find a large intravertebral instability, that is the defect opens up significantly, then the amount of cement you are injecting is far more than the amount of bone, and these fractures are likely to collapse. If there is a large anterior or posterior wall defect, chances of cement leakage are high. If there is a superior or inferior end plate break, you have to be careful because here the cement is going to leak into the disc space and cause problems. It may be difficult to do a vertebroplasty in a vertebra plana. Remember, as I said, severe respiratory disease, be careful, pre-existing vertebral infection or untreated coagulopathy. Finally, if there is neurologic deficit, if there is significant deformity, ligamentous instability, or contraindication to cement augmentation or failure of cement augmentation, then a formal surgery. But surgery is not an easy task. It is not to be taken up. A large number of patients have severe medical comorbidities. They are frail, they have sarcopenia, they have dementia, and the 1-year mortality of these patients is very high. In fact, even a 30-day mortality is in the range of about 2 to 3%. Anterior column reconstruction, Ram mentioned, you must remember that the posterior implant will fail unless you have an adequate anterior column which is weight bearing. So it can be reconstructed by doing a posterior shortening, which is what I've been talking for almost 20 years. Or you can reconstruct anteriorly using cement, cage, etc. Important is to mention is that you must have a posterior implant purchase, which is very good, which can be done by doing long segment constructs or using supplementary hooks or wires along with your screws. Newer screws are available, such as cement augmented screws, expandable screws, hydroxyapatite screws. You can use larger screws, longer screws, which will allow bicortical purchase. You can use thicker screws, which will give you better strength. You can increase the medialization of your screws, and there is a new technique called as cortical screws, which also help in this thing. So these are all that is taken, and along with this, you must not forget to give all your anti-osteoporotic medicine, because that is the primary treatment. So 80% of your fractures are going to heal without problems. If there is persistent or progressive pain, always rule out infection or metastasis. Burst fractures, pseudoarthrosis or ligamentous instability, delayed collapse. Vertebroplasty if there is pain without instability or neurology, and surgery for ligamentous injury, large intravertebral defects and neurologic deficit. With this, I like to thank all the audience who has watched this webinar, and I hope the Bombay Spine Society has given you a very clear and unequivocal message regarding the management of osteoporotic vertebral fractures. We've had a fantastic discussion. I would like to thank each one of the panelists, Dr. Ram Chadda, Dr. Vishal Shettiwar, Dr. Arvind Kulkarni, Dr. Vishal Kundani, Dr. Agnivesh Tiku, Ankit Patel, and Uday Pawar. And I would also like to thank our moderator who has done a fantastic job, Dr. Abhay Nene. And with that, I hand the mic back to our OrthoTV online group, that is Dr. Neeraj Bijlani.
So thank you very much for conducting a wonderful webinar. And we also thank Dr. Amit Jain and Mr. Javed and Mr. Chandraketu from Intas Pharma, Inara, the makers of Olimab and Terifrac, for bringing us this webinar. Thank you everyone, and good night, and have a nice weekend.
Thank you, Neeraj, and thank you, Ashok, for organizing this.
Thank
you. Thank you, everyone, for a fantastic webinar.
Tomorrow for the ASSI webinar at 4 o'clock.
Yes. Thank you, Bombay Spine Society, for a fantastic webinar.